Okay. Good morning. How is everybody? Good? Did you have a good weekend? Yeah. Valentine's Day weekend. Hope everybody got to do something fun. All right. So did you guys do your homework, chapters 2 and 3? I know it was a lot. It's a lot of reading, I know. That's the worst part of the homework. From here on, even though you have 2 chapters over the weekends, they're not nearly as bad as the first weekend. So just know it gets easier from here. Does anybody have any questions on what you read? Or any questions that you missed on the test that you need me to explain to you? Everybody good? Good. Okay. Emily, how did you do? Emily? Thank you. Michaela? Thank you. Tiana? Thank you. Good morning. Good morning. Mia? Thank you. Autumn? Yenison? Ashley? Eliza? Ariani? Christina? Thank you. Madison? Madison, do you have chapter 1 for me? Thank you. Ashanti? Okay, very good. Very good. All right. Oops. Let's go here. Any questions on anything before we jump into our review? Are we good? Is everybody kind of keeping up? Am I going too fast for anybody? Or do you understand kind of the premise of this, that we learn building blocks and we're going to put them together to make skills? Everybody kind of got what we're doing here? Okay. How do we know what to do with each patient? We follow and it's not just the care plan, it's the whole care plan and nothing but the care plan. While we're following that care plan, what else are we doing? Making observations. And then what do we do with those observations? Report them to the nurse. Very good. Every skill starts with the opening. Every opening starts with a knock. And remember, that is a graded checkpoint. That's something we have to do. Once we gain entry into our patient's area, we're going to do what? What do we have to say to them? Yeah, greet them. Hello, good morning. Be nice, right? You just don't want to walk in and say, I'm here to get you ready. We want to be nice about it. Once we greet them, we're going to address them in a very specific way. How do we need to address them? By name. Can we use honey, sweetie? No. In fact, it's funny because in one of the CNA groups that I'm in, somebody just posted in there that they failed their skills exam. And she said, all that I can think of is that I called her sweetie. And she says, but that's just my nature. I call everybody sweetie. Well, it's a graded checkpoint. So we have to practice this if that is your nature, especially if you're a server, right? Servers are really bad about that. Servers will call everybody honey or sweetie or darling or whatever because they think it's going to increase their tips. They're forming that personal connection. We can't do that with patients. We have to maintain some sort of a professional boundary. So be really, really careful about that, especially if you are a server. You're going to have to practice this to get that kind of out of your vocabulary. Does that make sense? All right, once we've identified our patient, what do they need to know about us? Name and title. That's right. And then we're going to describe what we're there to do. Yeah, I'm here to insert name of skill here, right? You can read it right off the care plan. You can put it in your own words. Nobody cares, but they need to know what you have planned for them. And then once you've got all of that done, what do we need to get from them? Consent. After we've got consent, then we're going to close the curtain. And is that curtain clean? So what do we want to do? Wash our hands. That's correct. Once we have clean hands, we can go get our clean supplies. Everybody understand the opening? Cardinal rule here, don't touch the patient until your hands are clean. Very important. Remember, we don't want to bring this patient anything that they don't already have as far as pathogens go. All right. For every skill we're going to do, we have to evaluate if we need gloves. So this is an evaluation step. You're not going to wear gloves for everything, but we are going to wear gloves when we need them. So how do we know when we need gloves? What are the 3 things we have to consider if we're going to touch body fluids? Okay, that would be non-intact skin. Yep. So body fluids, non-intact skin, and personal skin. Anything normally covered by a bathing suit, right? No squares, right? You don't want to be there without an extra layer of protection. Make sense? Good? All right. So if we decide that, yes, we need gloves for this skill, for one of those 3 reasons, either we're going to touch body fluids, or if there's a potential, if there's kind of an unknown there, right? If I'm not sure if there's body fluids, then we need to wear gloves. So if I'm going to touch body fluids, if I'm going to touch personal skin or non-intact skin, and I need gloves, what's the first thing they should touch? The patient. Keep your gloves clean for the patient. Limit what you touch with those clean gloves. If I'm going to brush your teeth, like if I'm going to be in your mouth, do you want me to have gloves that have touched everything else in the environment in your mouth? No, you want clean gloves. Well, so does your patient. Good. Once we have touched the patient, though, those gloves are now unclean, and we have to be careful what we're touching in the environment with those unclean gloves. Don't touch the curtain. Don't touch the bed controller. Don't, touch the sheet. Be careful about what you're touching in that environment with those unclean gloves. This is probably the rule that is broken the most in healthcare. Out of all the rules that we've learned, this one right here is the one that we break the most. And if you ever, if you have a family member that's in a hospital and you go visit, just sit back and watch. Because it's amazing how many times caregivers will put on gloves and they'll pick something up and throw it away, and then they'll get a cup of water for the patient and give it to them, and then they touch the bed controllers, and then they close the curtain, all of that with gloves on. And we want to be careful about what we're spreading around that environment. Good? Good. All right, and then if we've worn gloves, we have to know how to remove them correctly. We're going to pinch up near the cuff, and then we go underneath on the second hand. Any questions on glove rules? All right, we also learned barrier rules, because we have to have a clean place to put our clean supplies. And this table, not it. We need a clean place. So we're going to use a barrier on the table to create a clean place. A barrier can be anything. A barrier could be a paper towel, a Kleenex, a regular towel, a washcloth, Chucks. I mean, it can be pretty much anything. But we just want to separate our clean stuff from the not clean surface. Good? Make sense? All right. Remember that all supplies are clean, so you have to have clean hands to get those clean supplies. And we don't want the supplies to touch our uniform. That's correct. The best way to do this is not to get your barrier when you get your supplies, though. It's better to get the barrier first, put it on the table, and then the supplies. That way you don't accidentally hold those items, those supplies up next to your uniform while you're trying to spread out that barrier. Good. Speaking of supplies, we learned how to use a privacy blanket. A privacy blanket is used not just for privacy, it's also used for warmth. Remember, your patient is not active, not dressed for company, and they're in a cold environment. If you take that sheet away, they feel very cold as well as exposed. So we're going to use a privacy blanket anytime the patient is uncovered or undressed. Good? Okay. All right. When you put the blanket on, we put it over the sheet and pull that sheet down underneath. So we never truly expose the patient. They're always covered. They're covered with a sheet or the blanket, but they're always covered. We don't just pull the sheet down and then put the blanket on. When we put the blanket on, we don't snap it or shake it. We're going to lay it out, because if you snap or shake, it aerosolizes your pathogens. It brings them right up to your face level so you can breathe them in. That's no good. We don't want to do that. And then at the end of the skill, if you've used a privacy blanket, we take that blanket away after we remove our gloves. Because remember, we don't want our patient exposed. That means we have to pull that sheet up over the blanket as we remove it. Make sense? Okay. You don't want to touch that sheet with soiled gloves. Questions on privacy blanket? We also learned linen rules. Now, most of what we learned with linen rules are repeats of things we've already learned. We learned that linens can't touch your uniform. We've learned that you have to have clean hands to get your linens. We learned that you can't snap or shake your linens. This is all repeats. We already know this. We did learn one new thing, though. We skipped two. We're going to come back to those in a little bit. But we did learn that anything we take and don't use, then we have to discard it. You can't leave it in the room for later. All right. We're going to come back to those today. And then the end of every skill we do, the very end, is always done the same way with the closing. Now, the closing has a lot of steps, and they all start with C, so it can get a little confusing. But you want to make sure that your patient is in a clean and safe environment. So take a look around. This is the part of the skill where you have to step back and pay attention to the body in the bed. Instead of you and your steps and your skill and your checkpoints, I want you to take a step back during the closing and look. Do they look like they're in the middle of the bed? Do they look comfortable? Do they look like they need anything? Do they look cold? How do they look? Look at the patient and make sure that they're truly in a clean and safe environment. Is there trash laying around? Is the gown still on the overbed table and you didn't, put it in the hamper? Look at the patient. Once you've looked at the patient and they're in a clean and safe environment, I want you to look at the bed. The bed needs to be in the lowest position. Whatever goes up must come down. We got to put that floor back when we found it. If the bed is in the low position, now we can kind of move on. We want to make sure they're comfortable. So we want to say that word, are you comfortable? They actually need to hear this to check that checkpoint off. So are you comfortable? Can I get you anything else while I'm here? We also want to address their preferences, and this is all about emotional comfort. Can I get you something? A magazine, your TV remote, your cell phone charger. They got to have something to do. You guys are all sitting in here. If I took a 5-minute break, okay, if I said, all right, we're going to take a 5-minute break, don't touch your phones. You guys are all just going to sit here for 5 minutes with nothing to do. How comfortable are you? Some of you, particularly the older ones, would probably be okay for 5 minutes. Any longer than that, you're starting to get antsy. Younger ones, you've got about a minute and a half before you start to get anxious. That's how long our society is primed to go without some sort of entertainment and distraction. A minute and a half. It's crazy. It's crazy. That's having a big effect on our society, by the way, because it used to be years and years and years ago, boredom was actually good for you because boredom made you create. It made you create and craft your own entertainment. Now we've outsourced it. We rely on some sort of an electronic means to create and craft our entertainment. What do you think that's going to do in a couple of generations to our own innate creativity and problem-solving ability? So next time you reach for your phone, I want you to think about boredom is actually good for you, a little bit. But our society is so geared toward entertainment that if you guys can't go a minute and a half, this person probably can't either. So we want to make sure they have something, a book, a crossword puzzle book, a magazine, the TV remote, their cell phone. Good morning. So you want to address their preferences. Oh, no, you're fine. You're fine. Once you've addressed their preferences, we're going to cover them or look to see if they're covered, right? I should never see knobby knees. So are they covered with a sheet? Are they dressed? Do they look comfortable? This is, again, going back to look at your patient. And then you're going to open the curtain. We don't want to isolate our patients. And you want to give them their call light so they have the ability to call for help if they need it. After you've done all of that, nope, that's all yours. Oh, you're good. You're good. So you have to do all of those things before you go wash your hands, right? We're going to wash off all of those cooties. And then if we have to document, that's going to happen after hand washing. But if we document, we have this checkpoint that is end skill with clean hands. So if we've documented, now documentation is what is our last step, and this doesn't get checked off. So if we document, what do we have to do in order to get this checked off? Wash our hands again. Good. The whole purpose of the closing, guys, isn't just to get the steps checked off. It's to actually make your patient feel cared for and cared about. So with the closing specifically, I want you to slow down and make sure that you're focusing on the person instead of the patient. Does that make sense? There's a difference there. Make sure you're focusing on the person, and that will help you get all of those checked off. We learned how to wash our hands. Now, hand washing is not hard. We all have done it. You started learning this when you were about 2 or 3 years old. But we have to do it in a very specific way to remove the most amount of pathogens possible. So in order to wash our hands, we're going to wet them, get soap enough to develop a good lather, bring our hands together, and that starts our time. We're going to rub all surfaces, the front, the back, around the wrists, down to the fingertips for at least 20 seconds. We're going to use a clock for timing. Once we've scrubbed for at least 20 seconds, then we're going to move on to our nails. We'll go down each one of our nails with our thumb to get our cuticles, and then circle the nails on the palm of your hand to get underneath. Then you can rinse. When you're rinsing, keep your hands lower than your elbows. Don't touch the sink or the faucet so that we don't contaminate. And then we want to tap to keep the water confined in the sink area. Dry your hands. Doesn't matter how many paper towels you need. Throw those away. Get a clean, dry paper towel to turn that faucet off. How long do you have to scrub your hands for? At least 20 seconds. If you stop scrubbing and move to your nails at 19 seconds, they don't believe in close enough. You will fail. So at least 20 seconds. I would probably give it 22, 23 just to be safe, because they are timing you. Good? But there's no need to do like a 3-minute surgical scrub. That's not what we're doing here. Remember, they want to be at home in their pool drinking their margaritas. They don't want to be watching you scrub for 3 minutes, 20 seconds. We learned how to take a pulse. Now, a pulse is a measurement of how many times the heart beat over 1 minute. And our care plan tells us which pulse to take, the radial pulse measured at the wrist. We're going to use our fingertips, not the flat area, and never our thumb. You put your thumb on the pulse, you may get your own pulse, which isn't going to help us. So 2 fingers, fingertips, not flat part, over the radial pulse. Now the radial pulse is located at the bendy part of the wrist, not down here, bendy part of the wrist on the thumb side. So not down here, it's up here. So if you trace the thumb down to the lines, that's where your pulse is. Put your thumb on the back to hold consistent pressure so you don't lose it. Normal values are between 60 and 100. We hope we get normal, but we may not. I mean, your patient is, after all, in a clinical facility. They've got something wrong with them. So it may not be normal. What do we do with anything that's not in that normal range? Report it to the nurse. Absolutely. This is a documentation skill, so please make sure you document what you got. Having that number in your brain doesn't do the nurse any good. We learned how to dress a resident with a weak arm. We're going to ask them what they want to wear. We're going to get the clothing first before we undress them. We're going to lift from below with a flat arm when we lift. We undress the strong arm first. We dress the weak arm first. We make sure that we don't overextend or force movement. We lift extremities from below with a flat palm. And we make sure at the end, everything looks good. All the buttons are matched up right. The pants are up over the hips. The toe seams are lined up over the toes. We want the call light in the stronger hand at the end. Good? We learned how to do range of motion. Remember that we do exercises to retain function. We're just trying to keep what they've already got. We're not trying to make anything better. We're just trying to keep it from getting worse. So retain function. So we don't do pain. If the patient looks like they're in pain, complains of pain, anything like that, we go below the level of the pain for the next repetition, and then we let the nurse know afterwards. Good? Makes sense? Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. There is no rotation on the state exam. We're going to exercise the body part the care plan tells us to, the number of repetitions the care plan tells us to, and the exercises that the care plan tells us to. So this is a recipe. You just read the recipe and do it. It's a pretty easy skill. Lift from below with a flat palm. Remember that a range of motion is a full range of motion all the way back to start. Good? Good? All right, so when we're looking at all of the principles that we have to learn, there are 11 of them. We now have everything covered except for 4. That's all we have left to learn. Everything else we've already been over today. It wasn't very hard, was it? Okay. So we still have 4 to go, and today we're going to learn 3 of them. So by the time we get to Wednesday's class, where we learn the last one, the majority of the learning is behind you. So the halfway point, it gets easier from there. Because then we're just going to take all these principles that we've already learned and plug them in and create skills out of them. Good? Pretty easy. All right, so let's jump in and go to page 116. This is hand and nail care. If you look at all the principles down the side, you'll see that this is going to use a lot of principles. They're all spelled out for us here on the page. We're going to use skill rules, opening, glove rules, barrier, linen rules, basin cleaning, or washing rules, basin cleaning, and the closing. So we have a lot of principles that we're going to apply to this particular skill, but it's not a hard skill. If you look at the bottom, test specific information. So this applies just to the test. Somebody with your level of experience, which is none, should be able to do this skill in 11 minutes or less. So I'm going to tell you in shorthand what the skill is. You're going to put the one hand, because our care plan is going to tell us to do one hand. You're going to put the hand in the basin to soak, take it out of the basin to wash, put it in the basin to rinse, take it out of the basin to dry. We're going to clean under the nails. We're going to file the rough edges, and we're going to put some lotion on. And they're going to give you 11 minutes to do that. That's an incredibly long amount of time. Don't rush this. You don't need to rush this. There is plenty of time to get all of the steps done. Good. If you look at the second position there, you'll see that this is going to be done on you, another testing student. So you might be a patient for this. That patient's going to be positioned in a chair at the beginning of the skill. Documentation is not required. So if we go to page 117, this is going to give us our step-by-step instructions. At the top of the page, we have a care plan. That tells us exactly what our care plan is going to tell us to do on the state exam. Below that are step-by-step instructions. If you follow this, if you read the step and do it, you will absolutely get 100% on the state exam. At the bottom of your supplies. Now, this skill is our first skill that has a lot of supplies. And there's no way around this, guys. You have to memorize your supplies. I'm not going to tell you, go do hand and nail care, and you're going to need to take with you 2 washcloths, a basin, soap, lotion, an orange stick, an emery board, and a barrier to put it on. I'm not going to tell you that. I'm just going to say, hey, go do hand and nail care. You got to know what you have to take in. So there's really no way around this, guys. You just have to learn the supplies. Let's take a look at the care plan. Care plan, flashcards will help you with supplies. Make your own, buy mine, doesn't matter, but you're going to need some flashcards to learn this, okay? Let's look at the care plan here. The care plan says to provide hand and nail care to one hand. How many are we doing? What if the patient has 2? Care plan says 1. You get to choose which one. It doesn't tell you right or left. For the test, you're going to get to choose. In a real life setting, if they're only asking us to do one hand, that means the other hand, for whatever reason, can't have hand and nail care done. Maybe it's in a cast. Maybe there's an incision. Maybe it's got the external fixation, which looks like metal scaffolding all around it, holding bones in place. I don't know what maybe it's missing. I don't know. I mean, I have no idea what patients you're going to come across in your clinical, experiences. So if it says one hand, it's going to tell you which hand to do because the other one can't be done. Does that make sense? But for the test, they don't indicate that. So you get to choose. Pick one. Good? All right. It says the patient is sitting in a chair at the bedside table and can move as directed. So that means you can ask the patient, can you place your hand in the basin? You can ask your patient, can you take your hand out of the basin? The patient can move. They're not invalids. If we help them with that, we want to support from the bottom. That's a rule. We already know that rule. Always support from the bottom. Good? All right, but if you look at all of the principles involved, there's 2 we don't know yet. So we have to learn those in order to learn how to do this skill. And we're going to start out with washing rules. There are 5 washing skills that we are going to learn. This is the first one. But these rules that we're about to learn are going to apply to 5 skills, which is a quarter of all skills we do, by the way. I have a video for this, but we're not going to watch the video. I'm going to talk to you instead. Your notes are on page 113 for this particular skill. And in order to understand washing rules, I want you to think about how you bathe. How do you bathe? You probably turn the water on in the shower, let it get warm, and then you get in and you get wet. Then you get whatever you use, a loofah, a sponge, a little puff, silicone, whatever you, washcloth, whatever you use, and you put some soap on it. And then you wash your body. What do you do after you wash your body? You rinse. Would you ever get out of the shower without rinsing? No, that's just weird. You would feel sticky. You'd probably feel a little itchy, but you definitely would feel off, right? Well, we don't really think about that. It's just part of our routine. We get in, we get wet, we soap up, we rinse out, rinse off, we get out, we dry off, right? Those are just steps that you wouldn't just get out, not dry off, and try to put your clothes on while you're still sopping wet. It doesn't make sense to us. The problem is that when we are doing these steps on someone else, those steps become a little blurrier. We're going to take those same steps. We're going to wash, we're going to rinse, and we're going to dry. But chances are when you're doing this on someone else, you will forget one of those steps. You will. You'll forget to rinse or you'll forget to dry. It's just, for some reason, when we're doing this on someone else, it's never something we would do to ourselves. We are definitely not going to forget to rinse off ourselves. But when it comes to another person, we do forget. So I want you to remember in your head that whatever we wash, we rinse. Whatever we rinse, we dry. Make sense? Okay. So think about yourself, right? If we're going to wash and we need to rinse, that means we need a source of clean water to rinse with. Now, when you're in the shower becomes your clean source of water. You wash and you rinse right there. But if you're bringing everything over here to the table and your patient is sitting in a chair at a table, we have to have a way of rinsing whatever we've washed. They're not in a shower. They're not at the sink. We have to be able to rinse here. So if we need rinse water, that means that we cannot put soap. Okay. We cannot put soap in that water. Because if you put soap in the basin of water, you can't rinse with it. Does that make sense? Good? Okay. So the first rule here is basins are no soap zones. Soap does not go in the water. Soap goes on a wet washcloth. Good? Make sense? Okay. All right. So when you are getting a shower, you turn the water on and you let it get warm, and then you get in the shower, and you usually put your hand in there to check that water to make sure it's warm enough for you, right? Am I right? You don't just turn the water on and jump in while it's still cold, unless you're in a really big hurry, because it's not comfortable, is it? No, we're going to wait for that water to warm up. Well, when we are getting water for our patient, we have to do the same thing. We're going to check that water with the inside of our wrist. And it should feel warm, not hot, not cold, just warm. And then once we check that water and we get it in the basin, we're not the only ones that have to check that water. The patient needs to check it too. We're using that water on them. And we have to remember that everybody has different preferences. How many of you guys like super hot showers? Like steam billowing? You want it to take your skin off, right? It's got to be hot, hot. Okay. I'm that person. I love hot showers. The hotter, the better. My husband is the exact opposite. He works outside all day in the heat. He doesn't like hot showers. He likes cooler showers, right? We all have different bathing preferences. So if I get water for a patient and I like super hot water, what kind of water do you think I'm going to get for my patient? Probably super hot water, because I'm thinking like me, not like them. So if I take that water over to the patient and they don't like super hot water, we're probably not going to get along today, are we? So remember that help isn't help if it doesn't help. Have I told you guys that already? Help isn't help if it doesn't help. Well, if my patient has a certain water preference, it's my job to make sure that the water I'm providing meets their preference, not mine. The only way to find that out is to ask them to check the water temperature. So I'm going to go to the sink. I'm going to get some water. I'm going to feel it with the inside of my wrist. It should feel warm, not hot, not cold. I'm not bathing me. I'm bathing them. And then I'm going to take that basin over to the patient. And I'm going to ask them, is this okay? If they say, oh, it needs to be warmer, am I going to argue? No, I'm going to go warm it up. If they go, oh, that's too warm, am I going to argue? No, I'm going to go cool it down. We are bathing them, not us. My opinion has no bearing on this because I'm not the one being bathed. Make sense? Good. Are you starting to see that the test is really all about the patient? It's not about us. None of these steps have anything to do with us. It's always about the patient. And if you can make that change in your brain, the test becomes super easy. If you start to think, how would I want to be treated if I were the patient? You will automatically do that as a CNA. And you will get 100% on the test. Because that's what they're grading you on. Good? Makes sense? All right. So basins are no soap zones. We're going to check the water. It should feel warm, and the patient needs to check the water. When we get the water, we have to think about the faucet. Now, let's think for a second how we went about this, right? We did our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? Close curtain, wash hands. Get clean supplies. Put them on my barrier. So I've had clean hands and I've only touched clean supplies. And I'm getting ready to touch the patient, but I need some water. So I take my basin over to the sink. Is that faucet clean? No, but my hands are. So how do I turn the faucet on to get my water without contaminating my hands? Paper towel. Very good. Very good. So we use a paper towel to turn the water on and then check it. We're going to use warm water, not hot, not cold, and we're going to ask our patient to check it as well. Now, let me explain to you why the patient needs to check it. And this is a little bit about aging physiology, how our bodies change as they age, okay? And this isn't really not common knowledge, okay? But we have layers to our skin. You've got a skin layer, you've got a fat layer, you've got a muscle layer, but there's layers there. When we're young, those layers are nice and plump and big and juicy, and they protect everything underneath. Those layers shrink with age. Have you ever seen an old person's hand? They look like this. I'm getting older, so I can't do this much longer. But there is a difference between my hand and what you see on the screen, isn't there? Now, I want you guys, because you're young, I want you to hold up your hand and compare it to that screen. Is there a difference? Those veins, very prominent. Very prominent. This person has lost the fat layer underneath their skin. And this happens during aging. It happens mainly in our extremities, but it's something that we need to be aware of because that fat layer actually does a very important job. It's an insulator. Anybody know what normal body temperature is? Okay, 98.6, that's normal. It's actually kind of a range, 97.6 to 99.6. We picked the one in the middle just for easy, right? 98.6 is considered normal, right? What do you think the room temperature is in here? Okay, let's use 75 because I like easy numbers, Okay, let's just use 75. So if the room temperature is 75 and our body temperature, again, I like easy numbers. Let's just pick 98. Let's just drop the decimals, right? So if room temperature is 75 and body temperature is 98, is there a difference in that temperature? Yeah, there's a big difference in that temperature. So how does our body stay warmer than the environment? Because here's a physics truth. Room temperature always wins. Always. If you take a pie out of the oven, that pie baked at 325 degrees, you take that pie out of the oven and it's all bubbly. If you touch that pie, as soon as it comes out of the oven, what would it do? It's going to burn you because that pie is 325 degrees. It is hot. I put that pie on the top of the stove and leave it there for a couple hours. What happens? Cools down. It actually cools down to room temperature. Doesn't ever go below room temperature. It'll never go colder than room temperature. Now, pie goes well with ice cream. So let's open up our freezer and get our ice cream out. And ice cream is, let's say, about 0 degrees Fahrenheit, right? And you put that ice cream on the counter and it's cold. But you leave that ice cream on the counter for a couple hours, what happens? It melts. It warms up to room temperature. It never gets above room temperature, but it'll warm to room temperature. So now we got pie and ice cream that are both room temperature, and they will stay room temperature forever. Even though they started out hot and they started out cold, room temperature always wins. It's a physics principle. Now, why do we care about that? Because if our bodies have to stay at 98 degrees and room temperature always wins, there's a problem there, isn't there? So let me explain to you just how narrow our body temperature range is to support life. If you get below 95 degrees, you have hypothermia. If you get below 93 degrees, you are dead. Room temperature is 75 degrees, and we can't be below 93. Incompatible with life. So how in the world do we stay above 98 if room temperature is trying to drag us down to room temperature? How does that work? Well, you would think that we would be more comfortable in like 98 degree room temperature, but has anybody been in a 98 degree room? How do we describe that? Hot. We can't handle that kind of heat. It's too hot for us. We are comfortable at 75 degrees. So how does this work? Have you guys ever heard of the term burning calories? Have you heard that? Burning calories? Okay, when you eat, that digestion process creates heat. You literally burn calories to stay alive. That's one of the biggest reasons you eat. You eat for nutrition too, but that's kind of a side effect because you will die of hypothermia long before you die of malnutrition if you don't eat. If we don't have the ability to burn calories. Make sense? Kind of crazy, right? Kind of crazy. All right. So that takes a lot of energy, right? To keep us at 98. 98 is a long way from 75. That takes a lot of energy to keep us way up here so that room temperature doesn't win. It takes a lot of energy. So we don't want you to expend that much energy. So we put a layer of fat on you and it acts as a wetsuit. That layer of fat holds in that body heat that your body is creating and keeps you at that normal 98 degree level. So what do you think is going to happen to our patients when they lose that wetsuit? Their body heat is going to radiate away. They're burning calories, but they're not able to keep that heat inside effectively. Have you ever heard an old person say, "I'm cold"? I can't live up north anymore because I can't handle the cold. That's because the body heat that their body is generating is radiating away because they've lost their wetsuit. So when we lose that layer of fat in between our muscles and our skin, what ends up happening is your body can't retain the heat it generates, and outside heat is going to affect us much more strongly, okay? If you've ever walked into grandma's house and it's like 82 degrees and you're like, "Oh, grandma, it is hot in here. Let's turn the air on." And she's like, "Oh no, honey, I'm fine. Leave me alone." It's because she is adjusting her environment so her body doesn't have to work as hard, so she doesn't feel as cold. So now let's put that same person in a healthcare setting where we have the temperature down to like 70. They are freezing. Absolutely. Absolutely. Now, you are fully dressed, running around like a chicken with your head cut off, and you got all of your layers intact. So your temperature perception, completely different from theirs. But this is also going to affect their water temperature perception as well, because they don't have that insulation layer in between. They don't have any buffer. So water that feels warm to you might actually feel hot to them because you're feeling it through a wetsuit and they're not. Good? So we're going to check that water temperature. And this is why for older people, we use warm, not hot, not cold, just warm, because they're going to perceive that temperature a little bit different than we do. Good? So we always ask our patient to check the water temperature. Whatever we wash, we rinse. Whatever we rinse, we dry. And you guys don't have a lot of practice time in the first 2 weeks because I have too much to teach you. So the first 2 weeks, I'm teaching right up until 1 o'clock. There's not a lot of practice time built into the program. Starting in week 3, not on Monday, but on Wednesday, we usually have about 20 minutes of practice time built in. On week 3, Monday, we will have probably about 15, 20 minutes. Wednesday, we'll have about 30 to 40 minutes. And week 4, we'll have about an hour. Now, I have a sign-up sheet that I'll be passing around later this week. And the week between classes, so after you graduate, right? So you graduate on Wednesday, that following week, on Monday and Wednesday, you can come in here from 9 to 1 during classroom hours and practice. You have to sign up. It's by sign up only. So you have to sign up. Good morning. Good morning. So you have to sign up, but it allows you to come in and practice, okay, before you test. Now, you will realize this when you start practicing. So remember, on week 3, we're going to have a little bit of practice time. I would strongly suggest that you pick a washing skill to practice during practice time, because you will find that you are going to forget one of these when you're doing this on somebody else. You will either forget to rinse or you will forget to dry. Now, if you're the person that's being practiced on, if you're playing the patient, please remind them, because I want them to recognize that they have forgotten something. Good? Don't just stay quiet. Make sense? That way we can all learn. Okay? So what I do when I'm doing skills on somebody else is I actually say this in my head. Whatever I wash, I rinse. So then I know I'm on my rinse step. Whatever I rinse, I dry. So then I know that I'm on my drying step and I know that I've gotten all 3. Okay, good. If you leave soap on the skin, this is what it looks like, magnified. It actually dries out the skin and it makes it itchy, but it can also crack the skin. And that gives us another skin opening for pathogens. Not a good idea. This skills, they're giving us 11 minutes. It shouldn't take that long. Shouldn't be an issue for you, but pay attention. If your water gets soapy or cold, you need to change it out. Don't make your patient use cold water, or don't use soapy water to rinse, because that's going to affect the patient later. Dry surfaces should remain dry. So we're going to use a barrier on our table so that if our water spills, it doesn't go onto the table or the floor where it becomes a slipping hazard. This skill, we are going to use some lotion. We're going to warm our lotion up and then we're going to wipe it off, because if we leave lotion on the surface of the skin, it could cause a slipping hazard. So if they go to pick up a cup of hot coffee and they've got lotion on their hands, what could happen? It could spill and then it could injure our patient. Good? Okay, so those are washing rules. Like I said, there's a lot of steps there, and we're going to use washing rules a lot. We have 5 washing skills we're going to learn. The next thing we're going to learn is basin cleaning, and this is going to be on page 91 of our notes are on page 91. So basin cleaning looks a lot more complex than it actually is. And you're going to see this. Let me go back. You're going to see, we use basin cleaning on a whole lot of skills. You're going to see this over and over and over and over again. We clean all basins the same way, whether it's a bath basin, an emesis basin, a graduate container. If it holds a liquid, we're going to clean it the same way. And for the test, that cleaning is simply very easy. Rinse it, dry it, and store it. That's all we have to do for the state exam. Rinse it, dry it, and store it. That's it. Good? Makes sense? But there are going to be some instances where you have to disinfect. Not for the test, but in a clinical setting, there are going to be some times where we have to disinfect our basins. So we have to have a process that allows us to pass the state exam and allows for disinfection if we need it in a clinical setting. So that's what I'm going to show you here. Okay, good? Good. When we have a basin that's full of something, whatever that something is, whether it's water, body fluids, whatever it is, if we have a basin that's full of something, we have to figure out where to dump it. And we're going to dump it where it normally goes. If it's water, put it in the sink. If it's urine or feces, then that goes in the toilet because that's where it normally goes. If it's saliva from mouth care, where do you guys normally brush your teeth? Over the sink or toilet? Sink. That's where it normally goes. Okay. So water goes in the sink. Saliva goes in the sink. Urine and feces goes in the toilet. So dump it where it normally goes. Once you dump it, you're going to rinse your basin. Whatever the basin is, you rinse it out. But the rinse water has to go wherever you put the liquid. Okay, so if you're rinsing out something that held urine, you're going to put the rinse water in the toilet as well. Good? It's important to understand that basins are only used by that one person. When you go to the hospital, you get something called an admission kit that has basins and a water pitcher and all. That is yours. We're not sharing that with your roommate. We're not sharing it with somebody down the hall. If you get a bedpan, you are the only bottom that's going to sit on that bedpan. It is yours. You're actually going to pay for it. It's on your bill. Trust me, it's there. We don't share anything in healthcare. So because those things are just yours, you only have to rinse them, dry them, and put them away. You don't have to disinfect them after every use. because they aren't shared by other people. But there are some situations where you are going to have to disinfect. If your patient is on chemotherapy, we are intentionally obliterating their immune system. We are killing their immune system on purpose. Well, if their immune system is being killed, that means that they are at risk for infections. There's nothing on board to fight them off. So chemotherapy patients, we are disinfecting everything, because we don't want to introduce pathogens to our patient. Make sense? Good. If your patient has an immune deficiency like HIV, well, we would want to disinfect the basin. If the patient has a blood-borne pathogen, then we want to disinfect the patient because we know a pathogen is in it. Make sense? So there are some situations where we are going to disinfect, not for the test, but we have to learn a process that allows us to disinfect. So we dump the basin, we rinse it, we dump the basin, and then we're going to think about our disinfection. Do we need to or not? And we can't disinfect something if we're holding on to it with a dirty hand or a dirty glove. You just can't disinfect it if you're holding it. So what we're going to do is set it down in the sink. So we dump it, we rinse it, we dump it, we set it down, and then we spray it, not holding on to it. Once it's sprayed, we're going to pick it up with a paper towel because we don't want our dirty hand or dirty glove to touch that basin now that it's been disinfected. So pick it up with a paper towel. We're going to dry the inside with a paper towel. We're going to dry the outside with a paper towel. And then we have to put that basin in our 3-drawer unit. Should I touch the outside of this drawer with dirty gloves? So I need a paper towel to put it away. Now you're going to see this process over and over and over and over about 8 times. So if you didn't get it right away, it's okay. You're going to see it again. And remember, for the test, we're rinsing, drying, and storing. That's all they're grading us on. But I do want you to understand this process because if you have somebody that we need to disinfect it, the process counts. You're the only thing standing between them and a life-ending microbe. Good. Okay. So once we have everything put away, we will throw those paper towels away. So don't worry if you didn't get it. These are all the basins that we are going to clean throughout this program. You're going to see this a lot, but remember, for the test, we rinse it, we dry it, we store it. So now we know all of the principles involved in this skill. Let's look at the skill-specific steps that we need to learn. Okay? So this is our checklist. And using those principles that we just learned last week and today, you can see all the things that are already checked off, and we haven't even started the actual skill yet. Look at all those check marks that we've gotten. There's not much here that has to do with the actual skill itself. So this is, you can think of it as a mini mani, a mini manicure. We're going to soak the hand in water. That way it loosens up any debris that's under the nails. Just, anybody ever have a manicure? Right? You soak the hand in water, just like they do in a manicure. Then we're going to take it out of the water and put it beside somewhere on the table. But anytime we put a hand on the table, we want it on a soft surface. So we're going to put a towel there. So we put it in the basin to soak and then take it out and rest it on a towel. And then we're going to put soap on our wet washcloth and wash. Good. No soap in the basin. The soap goes on a wet washcloth. So whatever we wash, we rinse. So we're going to put it back in the basin to rinse. Whatever we rinse, we dry. So we put it back on the towel to dry. Once we've done that, then we're going to clean under the nails with an orange stick. This is an orange stick. Orange sticks have 2 ends. Hey, Jake, you might want to zoom for me. Zoomy zoom.
Sorry, I won't zoom or move at the same time.
Yeah, you're good. little more. Good. Okay, so if you're looking at the screen, you can see that one end is pointed and one end is slanted. The slanted end is what we're going to use. We take that slanted end and we put it right under the edge of the nail and circle it around. But now it has debris on it. Do I want to put that debris under the next nail? So I'm going to take that debris and wipe it on a towel before I put it under the next nail. Good? Questions? Stay there, Jake, please.
I literally hit the button.
Okay, so we're going to circle those orange sticks underneath the nails, wiping off in between each nail. The hand should be resting on the towel on a soft surface. Now we're going to use an emery board or nail file. CNAs do not use nail clippers. We do not use nail clippers, not in our care plan ever. Instead of letting the nails grow and grow and grow and grow until they're so long that we have to clip them, we do hand and nail care once or twice a week, and we file the nails to a manageable length, and that keeps us from ever having to trim them. Prevention versus fixing. Make sense? But the way that we file nails is going to be different than the way that you do it. Like if I have a nail that needs to be filed, I take this emery board and I probably go across the nail really fast back and forth to file the rough edges. This is the way that we do this on our own nails. The problem is that as we age, nails become very brittle. And if we go back and forth rapidly, it pushes and pulls that nail just like this. And when it does that, it can cause that nail to split right up the middle because it's brittle. It's not flexible. So we don't do that with older patients. Instead, we take that emery board and we file in one direction toward the center. This side would go toward the center, and then across the top, one direction. So instead of going back and forth, nail filing is always done one direction. Good? Good? Okay. Thank you, Jake. Anytime you move an arm, you're going to support it as we move it. And we're going to put lotion on after we've done all that and wipe off the excess. Good? So these are all the steps involved in this particular skill. So we're going to see how all of these steps can be combined to check off this checklist. So we're going to follow our care plan. Our care plan says one hand. So how many are we washing? One. We're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? Close curtain, wash hands, get supplies. We're going to decide if we need gloves. If the patient has a wound, a rash, an incision near where we're going to be, we need some gloves. If the patient does not, we don't need gloves. It's intact skin. We're going to wash our hands before, we're going to wash our hands after, but you don't need gloves to do this skill if the skin is intact. Now for me, I've got I don't know if you guys can see it, but I've got like my dog got me. I got a rambunctious dog, right? So I've got a skin opening here. You can see that it bled a little bit. Right? So if you were going to do hand and nail care on my right hand, you're going to be near an area of opening. Would you need gloves to do my right hand? Yeah. Now, there's nothing over here. Nothing wrong with this, right? All of my skin is completely intact. Would you need gloves to do this hand? No. Do you guys see the difference? Same patient, same skill. Do you see the difference? Good? Okay. So we'll evaluate if we need gloves. We're going to put a barrier down on our table to provide a clean place, but also to prevent water from spilling onto the floor where it becomes a slipping hazard. We're going to use our linen rules, not holding the linens up against our uniform. Anything we take and don't use, we're going to discard. We're going to use washing rules. So I'm going to get water with a paper towel. I'll check it. I'm going to have my patient check it. Whatever I wash, I rinse. Whatever I rinse, I dry. Right? All of those rules. If the water gets cold or soapy, I'm going to change it out during the skill. Lotion goes on last. I warm it up first. I wipe off the excess. We're going to clean our basin. For the test, that means rinse it, dry it, store it. And we're going to follow our nail care rules. So we'll support the arm as we move it. We soak the hand. We take it out of the hand to wash. We put it back into rinse. We take it out to dry. Clean under the nails, wiping off in between each nail. File the rough edges. Apply lotion last and wipe it off. Those same steps. And then we do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Bed is in the low position. Environment is clean. Here's your call light. Open the curtain. Wash my hands. That's the whole skill. Good? Questions? This skill is only on this one person. Just this one. This care plan is only for this person. I don't know why we're only doing one hand. Who knows? It's just what the care plan says for this person. Does that mean that that lady's care plan is going to be exactly the same? No, because she probably has two hands that need to be washed. Or maybe she goes to the nail salon twice a week and gets it done there. There are a lot of places that actually have people come in that does hair and nails. So she may actually pay somebody to do her nails and put pretty colors on them. I don't know. I have no idea what her care plan says. All I know is that this care plan is for this patient. Good? Questions? All right, so we're going to show you this video, and I'm going to pass the orange stick and the emery board around so you guys can see. We're going to watch this video. What do we have today? Okay. When you're watching the video, we're going to do make an occupied bed before we go on break. But when you're watching this video, pay attention to the bottom of the screen. You'll see the actual testing checkpoints as I'm performing the steps. All right, Jake.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm good. How are you?
Fantastic. I need to perform hand and nail care on one hand. Is that okay?
Yes.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, I need a towel and 2 washcloths. We'll bring this over to the patient area. From our bedside cabinet, we'll get a basin, soap, and lotion, and an orange stick and emery board. We'll set these items on the overbed table. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. And then throw the paper towel away. Mr. Jones, would you like to check the water temperature? Is it comfortable?
Yes.
Can you submerge your left hand in the basin, please? Thank you. I'm going to put the washcloths in here. And we're going to rinse your hand using the first washcloth. And now I'm going to place your hand over here on the towel. I'm going to take the washcloth, wring it out really well, and apply soap. Now I'm going to wash all surfaces of the hand. The thumb, each finger, in between each finger, we'll clean the palm of the hand as well. And the webbing between the thumb and the index finger. I'll set that aside. Mr. Jones, we're going to put the hand back in the basin to rinse. And using the washcloth, we'll just squeeze water over the hand to rinse. I'm going to turn your hand over, and we'll rinse the palm as well. Okay. I'm going to lift your hand up and place it on this towel, and we'll dry your hand using the towel. We want to dry all surfaces. We'll go ahead and turn your hand over. Make sure that all surfaces are dry. And now we're going to clean your nails with our orange stick. We're going to use the beveled end of the orange stick. We're going to clean under each nail, circling it around and wiping it off on the towel in between each nail. So we'll clean under the nail and wipe. I'm going to repeat on all nails. And now that the nails are clean, we're going to use the emery board and file the rough edges. We always file in one direction toward the center. I'm going to repeat on all nails just to make sure that the nail edges are smooth and free of any rough edges that might accidentally harm the patient's skin. Once the nails have been filed, we'll get some lotion. And we're going to warm the lotion up in our hands before we apply it to the patient's skin. So I'll rub my hands together to warm that lotion, apply it to all surfaces, making sure to coat all of the skin surfaces. And then we'll take that towel and wipe off the excess lotion. That way, it's not a slipping hazard if there's any lotion left on the surface of the skin. Now I'm going to take your linens and place them in dirty linen. I'll be right back.
Okay.
And I'm going to go clean your basin. I'll be right back. I'll bring the basin of water to the sink, dispose of the water into the sink, and rinse the basin. We'll dispose of the rinse water into the sink as well. I'll set the basin down, disinfect it per facility policy, and then use a paper towel to pick it up. I'll dry the inside with a clean paper towel. Throw that paper towel away. Dry the outside with a clean paper towel, and throw that paper towel away, and then get one for the drawer. On the way, we'll pick up the soap and the lotion with the paper towel, place them in the basin, and use the paper towel to open the drawer. We'll slide the basin, soap, and lotion in the drawer and close it with the paper towel. Now we can dispose of our disposables. So the emery board and the orange stick will go in the garbage along with the barrier. So we're just going to put these directly in the garbage can. Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. I'm just going to move this table out of your way. Here's your call light, Mr. Jones. If you need anything at all, please press the button and let us know. We'll be happy to come help. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done.
Am I unmuted? Perfect. All right. Any questions on that? It's a washing skill, so there's a lot of steps to it. Counts as kind of a bigger skill, but it's probably the easiest big skill there is. You're just washing one hand. You know, I mean, it's not overly complex. Now, a little bit later in the program, we're going to learn foot care, which is hand and nail care just on the foot, but we don't do anything with the toenails. Yay. We're going to soak the foot, wash the foot, rinse the foot, dry the foot, and lotion the foot. That's it for foot care. So foot care is theoretically a little bit easier than hand and nail care, but you have to get on the floor to do it. So to me, it's not easier because I can't get up very well. Any questions on that particular skill? Okay. So we're going to move into making an occupied bed. This is my favorite skill. I love this skill. It's kind of like a Houdini trick. It's pretty cool. So if you go to page 141, you can see the overview of this skill. Down the side here, you can see all of the principles that are going to be involved in this skill. They're all spelled out for us here. Short version of the skill is up here. Test specific information is here. Somebody with your level of experience should be able to do this skill in 14 minutes or less. This is changing an occupied bed, which means there's a body in the bed when we're trying to change the sheets. Now, two things. First, anytime you can get a patient out of bed to change their sheets, it goes a whole lot easier. It's easier on them. It's easier on us. It's just easier. So if you walk by a bed that's empty, there's no body in it, it's a really good idea to change the sheets. I can change an unoccupied bed, an empty bed, in less than 2 minutes. You put a body in the bed, and now it's going to take me probably closer to 8. So time management, always better to change sheets when there's nobody in the bed. But sometimes we have to know how to change the sheets while the body stays in the bed because for whatever reason they can't get up. Okay, and that's what we're going to learn now. Good? Make sense? But if you see an empty bed, consider, do those sheets need to be changed? Okay. For the test, it's always done on a bed just like this, a twin size hospital bed. They're not very big, so it doesn't take a ton of time to do this. If you're at home, you can practice this skill at home. I mean, all of you guys have a bed, right? Am I on pretty good terms there? Okay. You can do this on any size bed. You can actually do this on a king size bed. It's going to be a whole lot more work. It's going to take a little bit longer, but the mechanics of it are the same. But if you have a twin bed at home, practice this on your twin. So if you've got a kid, even a crib, if you've got a little one, you can do this on a crib or a toddler bed. This can be done on any size bed. But if the smaller beds are going to be more in line with what you're actually going to be doing on the state exam. Good. As a mom, I have done this more with sick kids in my own home than I did in a clinical setting. Because in a clinical setting, every time I walked by a bed that didn't have a body in it, I changed those sheets. So I very rarely had to change sheets with a body in it. Time management. And you'd be surprised, bodies are out of beds. Even bedbound patients, bodies are out of bed quite often. We get them out of bed in a hospital. They go to X-ray. They go to different, departments. In a long-term care facility, we put them on shower stretchers and take them to the shower room. Well, that's a great time to change those sheets. Okay. All right. So page 142 is going to have our care plan at the top, step-by-step instructions, and your supplies at the bottom. Let's take a look at the care plan for this skill. It says to change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. The resident can roll and move as directed. They just can't get out of bed. So I could ask this patient, can you scoot toward me and roll up on your side? That's fine. I can do that. Good. It just says they can't get up. All right. A bedspread, blanket, draw sheet, or underpad is not required for this skill. So all we're doing here is top sheet, bottom sheet, pillowcase. That's it. That's all we're doing. But those other things can be added in if we need them. So if we need a bedspread on, we can put that on over the top of the sheet. If we need a draw sheet, which is a sheet that goes underneath the patient, kind of like a sling. You can put a draw sheet on the bed, and that allows you to pull the patient towards you or up in bed. It just operates like a sling. An underpad is anything that's going to catch any fluids coming out of the patient. We can put any of those things on as we're doing the skill. We just kind of add it in. But we don't have to do that for this particular patient. So for this skill, if you're looking at all the principles, there's a couple things we have to learn before we can learn how to do this particular skill. So we have to go back to linen rules and learn the two that we skipped over. And then we also have to learn scoot and roll. So that's what we're going to focus on now. So one of the ones in linen rules that we didn't learn yet is clean rolls toward you, dirty rolls away. When you're changing anything underneath the patient on a bed, doesn't matter what that thing is, whether it's a sheet, a draw sheet, an underpad, whatever is going under the patient on the bed while they're in the bed, we use this. Clean rolls toward me, dirty rolls away. So if I'm getting a clean thing ready to go on the bed, I have to roll it toward me. On the bed, the dirty one that's under the patient is going to roll toward them. Okay? Everybody with me so far? Let me explain to you why. Okay. So let's say that we have a sheet on the bed and we have a body on the sheet. Good. Okay. I'm on this side of the bed. I'm going to turn just to the side a little bit so you guys can see. So I'm on this side of the bed. I've got a patient in the bed. Now, this is a dirty sheet, and I need to put a clean sheet on the bed. So I'm going to take that dirty sheet, dirty rolls away. So I'm going to take that dirty sheet that's on the bed, and I'm going to roll it away from me. Good? Jake, you might want to zoom in on me just a little. So I have this dirty sheet under a patient. It rolls away from me. And I want to roll it and tuck it underneath that patient so the patient kind of holds it in that roll. Now I'm going to take the clean sheet, spread it out, clean rolls toward me. So I'm going to roll that clean sheet toward me. And I'm going to tuck this clean one underneath this dirty one. So I'm going to lift it up and tuck it underneath that dirty sheet. Everybody with me so far? Okay. So I have a dirty sheet, dirty rolls away, tuck it underneath the patient. Patient holds that sheet in place. Clean sheet rolls toward me. And I'm going to take that clean sheet and tuck it underneath the dirty sheet. Now, when I do that, I'm going to pull this out just so you can see. This is the underside of the dirty sheet, right? So I'm not actually touching the part the patient laid on, the underside. Clean sheet, because I rolled it toward me, what's facing up is the underside of the sheet. So the underside of the clean one goes under the underside of the dirty one. And this is how we prevent gross pathogen transfer. Now, let's say, for instance, though, just for giggles, that this sheet that's under the patient is wet. Okay. So it's got urine or wound drainage or whatever on it, right? It's wet. Well, I don't want to put a clean sheet underneath a wet, dirty sheet. That just doesn't sound like a good idea. So what I'm going to do is take a Chucks. This is too big for my demonstration, but I would take a Chucks and I'm going to wrap that Chucks around the dirty sheet before I put the clean sheet underneath to protect it. Try not to let your patient fall on the floor while you're doing that. Let me get my patient. Where'd you go? Oh boy. Jake. Yes. Thank you. Thank you. I can't bend like that. All right. So we have the dirty sheet rolled toward the patient. Patient's holding it there. The clean sheet rolls toward me. I'm going to put that underneath the dirty sheet, and then we're going to have our patient go back to the middle. So when they're in the middle, do you see what they're laying on? A big bump. We're going to go around to the other side of the bed. So I'm going to come over here, and I'm going to have my patient turn away from me, and I'm going to take that dirty sheet off of the bed and smooth out that clean one, and then have the patient go back to the middle of the bed. This goes in the laundry. Good? All right, so clean rolls toward me, dirty rolls away. And that's how we change anything that's under the patient, whether it's a Chucks, a sheet, a draw sheet, whatever's under a patient, we're going to use that method for. Nothing touches the floor. Not clean, not dirty, definitely not the patient. Nothing touches the floor. So be very, very careful. Your items should stay on your barrier. Even dirty items, we're not going to put on the floor. And this is a little bit confusing for students because when you change your sheets at home, when you take the sheets off of the bed, where do you normally put them? On the floor. Yeah, we're used to that. That's part of our normal natural routine, right? We take dirty things off the bed, we throw them on the floor until we're done, and then we gather them up and take them to the laundry. Well, we can't do that in a clinical setting because nothing is allowed to go on the floor. We don't want to contaminate that floor with pathogens. So when you take things off of the bed, you have to have a place to put them. In a clinical setting, we usually don't keep dirty things in the room. So we don't have a hamper in every single patient room, usually. Now, this might vary if you're working in home care or something like that. But in general, we don't have dirty things in the room. You'll have a hamper that looks like on the far side there, you'll have a hamper in the hallway usually. There's like 2 hampers in the hallway spaced out. But we don't want to stop what we're doing and take this sheet all the way to the hamper or go back and finish. So what do we do with these items that we take off the bed if we can't put them on the floor? Well, you have a barrier on the table, and it's perfectly okay to place that dirty sheet on the barrier. No problem with that. I would try to not put it on top of the clean one, but it really doesn't matter all that much because the patient who made that dirty sheet dirty to begin with is still in the bed, right? We're not going for sterile here. As soon as you put that sheet under the patient has touched it. So you can use your barrier on the table to put your dirty stuff. I would just kind of carve out a little space for it. But you can also put a barrier on the floor and put your dirty items on the barrier. Now, most settings, it depends on your policy and procedure where you work as to how they want this handled, but most settings are actually going to use this. This is a soiled linen bag. Everybody familiar with Tide Pods? Right? They're just little packets that you throw in the washer. Well, this is the original Tide Pod. These have been around for like 40 years. Tide Pods haven't. So what this is it's a water-soluble bag. So if I take linens off of the bed, I put them in this bag, that whole bag goes directly in the washer. And it breaks down with water, and there's soap actually impregnated in the bag. So the bag itself becomes the soap to wash the linens. It's a great system because what it means is that people don't have to shake out all these linens and put them into laundry. The whole thing just goes in. It's a great system. Now, the problem with that system is if you put anything in that bag that shouldn't be washed, it's going to be in the washer. So when you're changing these linens, if you're not paying attention and you put you wrap it up and there's a hearing aid in there or dentures or a cell phone charger, nobody's going to catch it before it goes in the washer. So your responsibility as the CNA, when you're taking linens off of a bed, is to check to make sure that there's no foreign objects in those linens as you're changing the sheets, because nobody else is going to catch it. This is what your most policies and procedures will tell you to use. Okay, go get a soiled linen bag, take it in the room with you, open it up, put it on the floor, and all of your dirty linens are going to go straight into that soiled linen bag as soon as you take them off of the bed. Now, what are we going to use for the test? For the test, they will actually have a laundry basket or a hamper of some sort right next to the bed, either at the end of the bed or right next to the bed. So you're just going to put everything in that laundry basket or that hamper for the test. They'll tell you that. The big thing is don't put anything directly on the floor, ever. Does that make sense? Good. All right. There is a room in most facilities called a soiled utility room, and this is where all dirty things are kept. So sometimes your hampers will be in a soiled utility room. Nothing clean can ever go into soiled utility. Please be careful about that. If you've got clean, if you went and got clean supplies, don't go into soiled utility with those clean supplies. The clean rooms have to stay clean. Dirty rooms have to stay dirty. Make sense? Okay. So we already know this, use it or lose it, right? Use it or lose it. We don't save anything in the room for later. So we now know all of linen rules, but there is a new principle we have to learn, and this is scoot and roll. For the test, if you, how do I put this? You cannot rely on side rails to keep your patient safe. Whether there's side rails on the bed or not for the test, depending on your testing center, you can't use those as your sole means of keeping the patient safe. For the test, that patient must be in the middle of the bed at all times, the middle of the bed. Side rails don't count. Does that make sense? Okay. Side rails are a restraint. So this is the checkpoint that we're worried about. Keep resident positioned a safe distance from the edge of the bed at all times. Even if you have a side rail up and you put that patient, you roll them, you put them right up next to that side rail, you're not going to get this, because this doesn't say provide safety. It says keep the resident positioned a safe distance from the edge of the bed at all times. Does that make sense? Okay. So we have to kind of look at what side rails are and what they're not. When you have a baby and you put that baby in a crib, it's specifically to keep the baby safe, keep them confined. But what do you think happens once they hit about a year old? What do they start to do? Climb. Now, is that crib still safe for them if they're climbing? No, and it actually makes it much more likely that they're going to get injured, because now they're not falling from this level, they're falling from this level. And it actually increases the risk of injury. Does that make sense? Same thing here. When you have a bed with side rails, just like a crib, we start, young, like a year old, we start realizing we don't like to be confined. And we learn how to get out of confining situations. We climb, right? That doesn't ever go away. That need to not be pinned in doesn't ever go away. You become independent with your own body autonomy when you are a toddler. It doesn't ever go away. So when we put a patient in a hospital bed, we put side rails up and we tell them, stay. They're probably not going to, because that need for bodily independence is strong. Does that make sense? So this patient, if they try to get out, we didn't make it safer for them. We actually made it much more dangerous. And this is why side rails cannot be used routinely. CNAs never get to make the decision that side rails should be used. Nurses do not get to make the decision that side rails should be used. And this all has to do with a concept called false imprisonment. Anybody ever hear that term, false imprisonment? What does it mean? What does it mean, false imprisonment? Anybody? Yeah. Well, that probably could mean that, but as a legal principle, it actually means something else. It means to restrict the mobility of another person unlawfully. So if I come over to you and I tie you to that chair, and no matter what you try to do or what you say, I don't let you up. Do I have the right to do that? No. Even though you're in my classroom, do I have the right to do that? That's not what you signed up for, right? That's false imprisonment. I have restricted your freedom of mobility without your consent. That's exactly what this does. It restricts the patient's freedom of mobility without their consent. There's only two kinds of people that can do this legally, and both of them are temporary. One of them is the cops. The cops can put you in handcuffs and restrict your freedom of mobility legally, but only for a short time. You have to go in front of a judge for them to decide what to do. The other person is a doctor. A doctor can temporarily restrict your mobility with side rails or other restraints, but again, it's short term. You have to go in front of a judge for anything longer. This is a legal principle. A lot of CNAs screw this up. A lot of CNAs will put side rails up on the bed thinking that they're keeping the patient safe. They do not have the legal right to do that. You can be charged with false imprisonment for using side rails without a doctor's order. It's not a decision you're allowed to make. So because most facilities can't trust that CNAs understand this concept, most of your settings will not have side rails available. They won't even be on the bed because we can't trust you. If we get an order for side rails, maintenance has to come put them on the bed. They won't even be there. Does that make sense? Everybody understand that? You don't have the right to restrict another person's mobility, even in the name of safety. All right. But you don't need side rails to keep the patient safe. Just keep them in the middle of the bed. Side rails actually cause a whole lot of death because patients in bed, just because the side rail's up, that's not going to keep them from trying to get out of bed. What you've done is create an obstacle. And what usually happens is this. We put a patient in bed, we say, you're a fall risk. We put the side rails up and we leave. We go take care of other patients. That patient has to go to the bathroom. They hit the call light and they wait and they wait. Well, you're busy doing something else. You don't answer that call light right away. And they wait and they wait. And now they've really got to go. And they wait and they wait. And your mindset is, well, they got the side rails up. They can wait a little bit. They're fine. They're safe. I'm going to keep doing what I'm doing. And they wait and they wait. How long do you think they're going to wait? Yeah, they're going to wait only until it is now an emergency. They've really got to go to the bathroom. I mean, really, really, they cannot wait anymore. They are not going to pee themselves. They're going to get out of that bed and they're going to go to the bathroom. Right? And what we've done is actually created a much less safe environment for those patients. Side rails kill about 200 people a year. We can't use them without a doctor's order. Good? Okay. A lot of people think that they need side rails because their patients are weak, right? My patient's a fall risk. And I used to be one of these nurses that thought side rails were there for patients that are weak until somebody pointed this out to me. If you have a weak patient and you put them in bed and put the side rails up and restrict their mobility, that does not do anything to make them less weak. It actually makes them more weak because now they're not moving, which means their muscles are going to atrophy more, their strength is going to diminish more, and we are effectively going to make them weaker. And you can take somebody, put them in a bed with the side rails and make them totally bedbound for the rest of their lives in less than a week. That's horrible. That is not a power anybody should have. Does that make sense? Side rails do not keep your patients safe. They don't do anything to make them stronger, and they don't restrict falls. Good? Now, there is a difference between side rails and half rails, though. Half rails are also called positioning rails. They're these rails here that are at the very top of the bed. They don't restrict your patient from getting out of bed. The patient can still swing their legs out. It's not restricting their ability to get out of bed. These half rails you'll see on most beds because the patient can grab them and use them to boost themselves up or turn over. These are positioning rails. If this rail was up, it would be a side rail. Make sense? Okay. So like these are hospital beds. You'll see a side rail like this. Most of them are up and they're to help the patient with mobility. The side rails on the bottom of the bed are the ones we're talking about. Okay. But we don't need side rails. Basically, keep your patient in the middle of the bed and they're safe. So if I'm going to turn my patient on their side, so let's say I've got this lady in bed, right? And I'm going to turn her on her side to change her sheets. If I just turn her on her side, she's very close to the edge of the bed. Is this safe? Is she in the middle of the bed? No. So we're actually going to do what you do. We're just going to do it in 2 steps. When you're laying in bed and you roll onto your side, you don't roll, you shift. So your butt is in the same place after the roll. It's just facing a different direction, right? So you kind of lift up and shift to turn over. Make sense? You don't just roll, you shift. Well, I'm going to do the same thing with her, but I'm going to do it in 2 steps instead of 1. So instead of her lifting her body and shifting onto her side, what I would do is ask her to scoot toward me. Just going to pull this down so you can see. Ask her to scoot toward me so she's a little bit closer to me on this side. And then I would roll her on her side. And when I do that, she's in the middle of the bed. So this is scoot and roll. 2 steps so that after the roll, they're in the middle of the bed. Good? Good. You never want the patient to be close to the edge of the bed after a turn. So if you scoot them towards you or ask them to scoot towards you, either way, and then roll them onto their side after the roll, they're in the middle of the bed. And that's what we're going to do when we're changing this bottom sheet. We want them to take up the smallest amount of space in the bed when we're changing that sheet. So we're going to scoot them toward us, roll them on their side, and then change the bottom sheet on the side that we're on. Clean rolls toward me, dirty rolls away. Good? When you turn a patient on their side, always turn them away from you. This has to do with body mechanics and gravity, because gravity will always try to pull somebody back onto their back. If you've turned them towards you and gravity's trying to pull them away from you, the risk of injury is much higher. So side rails on the exam are not graded. You have to provide safety without them. So now we know the principles for this particular skill. Hey, Jake, make a note. Class 3, slide 150. Change banner. Thank you. All right. So when we're talking about bed position, there's a couple of different positions we have to talk about. We have to talk about the head of the bed, the foot of the bed, and the entire bed. Head of the bed is at the beginning of the skill based on safety. So if we're going to brush somebody's teeth, the head of the bed has to be up. If we're going to feed them, the head of the bed has to be up. Foot of the bed, not addressed on the state exam at all, but we have to know it does exist. Patients can elevate the foot of the bed for swelling or whatever, comfort. But this is the one I want to talk about. For this skill, making an occupied bed, we are going to be doing a lot of physical work. This takes a lot of physical effort. Now, this bed is pretty low. That means that for this skill, I'm going to be bending for quite some time. This puts a lot of pressure on my lower back. So if I'm going to be doing this over and over and over and over and over in a 12-hour shift, then by the end of the shift, I'm going to be hurting. So what I can do is raise this bed up to a comfortable working height for me. And that's perfectly okay. It's allowed. So you can raise the bed up if you want for the test. But at the end of the skill, what do we need to do? Lower it. Yep. So for this skill, you're not going to see me raise the bed because I'm kind of short. It's only one skill. So you don't see me do this step, but I want you to understand that you can if you want to for the test. You just have to remember, if you do, lower it at the end of the skill. Very important when you're changing that bottom sheet that the patient doesn't end up on the bare mattress. The patient always has to be on a sheet of some sort. That's why we change it a half at a time. We're going to roll that dirty sheet toward the patient. We're going to put the clean sheet on the bed, roll it toward us, and tuck one under the other. So the patient isn't on a bare mattress. All right. So this is what it's going to look like. Your patient's on their side. We've rolled the dirty sheet toward the patient, tucked it under them, put the clean sheet on, secured the corners, rolled the clean sheet toward us, and tucked it underneath that dirty. And then we're going to have our patient. So this is what it looks like if we were to raise the patient up. This is what it looks like. It's a roll underneath their body. So when we have them come back on their back, they're laying on that roll. We're going to go around to the other side of the bed and repeat the process. Have them scoot towards you, roll away, take the dirty sheet away, and secure the clean one. Make sure all 4 corners are secured, and then you're going to put the top sheet on. We want to minimize wrinkles under the patient. Wrinkles contribute to bed sores. We'll talk about that next class. Hospital corners, keep those sheets off the ground. Remember, we said nothing touches the floor. That's what hospital corners do. They just keep those corners of the sheet underneath the mattress. I'm going to show you how to make good hospital corners, but it's not graded how pretty they are. Just get the corners of the sheet under the mattress so they're not on the floor. We don't want them to be a slipping hazard. When you put the bottom sheet on and you tuck the bottom of the bottom sheet under the mattress and make your hospital corners, that's going to make that sheet very tight on their toes. It's going to force their feet down. We don't want that. So you want to loosen that sheet over the toes to give them some wiggle room in there. Okay. Last thing we do is replace the pillowcase. Now, it has to be last because we want to limit the amount of time your patient is without their pillow. So you put the bottom sheet on, you put their top sheet on, you make your hospital corners, and then you take the pillow away, change that pillowcase, and put it back. Good? Questions? Limit the amount of time without the pillow. So now that we know all of our steps, let's put them together to get our check marks. We're going to follow our care plan. We're going to do our opening. We'll evaluate if we need gloves. We're going to use a barrier. We're going to cover the patient with a privacy blanket because we're taking their sheet away. We're going to follow our linen rules. Don't hold anything against your uniform. Nothing goes on the floor. Clean rolls toward me, dirty rolls away. Scoot and roll to make sure the patient is always in the middle of the bed. We're going to follow the steps. Keep the patient from lying on a bare mattress. Replace the sheet one side of the bed at a time. Clean rolls toward me, dirty rolls away. Remove the bottom sheet. Secure the clean sheet. Smooth any wrinkles. Replace the top sheet. Make hospital corners. Loosen sheet over the toes. Replace the pillowcase and limit time without the pillow. And then we'll do the closing. Thank you very much, Ms. Jones. Is there anything else I can do for you? Are you comfortable? Would you like a magazine before I go? Environment is clean. Bed is in the low position. Here's your call light. Open the curtain. Go wash my hands. I'll review that care plan one more time just to make sure I've got all the steps. And then I'm going to tell the evaluator my skill is done. Good? Remember, this care plan is only for this patient. Every care plan you have for making an occupied bed will probably be a little bit different. We're going to follow those instructions for that person. Good? All right, we're going to watch this video. It doesn't take very long, and then we'll take our break.
Hello.
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I'd like to change your sheets. Is that okay?
Yes.
Let me close your curtain, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get the supplies I need for this skill. So we're going to start with a barrier, putting it on the overbed table. This gives us a clean place to put our clean supplies. And then to make a bed, we're going to need a pillowcase, a top sheet, a bottom sheet, and a privacy blanket. We're going to start with the bottom sheet. So I'm going to place a privacy blanket over you. This is going to help keep you warm and provide some privacy as we do this skill. So I'll spread this out, being careful not to shake it or snap it, and lay it in place. I'm going to pull your top sheet all the way down, and we'll remove it from the bed, wrapping it in a ball so that the trailing edges don't contaminate other surfaces. We're going to lay this on an unused part of the barrier on the table. Mr. Jones, can you scoot your whole body toward me? And then I'm going to ask you to roll to that side so you're in the middle of the bed. Thank you. We're going to remove the sheet from the top and the bottom of the bed, and we'll roll this toward the patient. Dirty always rolls toward the patient. And we're going to tuck this in under the patient's body, all along the length of their body. Now we'll take the clean sheet, unfold it, and spread it out on the mattress, being careful not to shake it or snap it or let it touch the floor. We'll secure the corners. And then we'll take the clean sheet and roll it toward us to minimize wrinkles. And then we're going to lift the bottom sheet and tuck this clean sheet underneath the bottom sheet, all along the length of the body. So we'll roll it toward us. And then tuck it underneath the soiled sheet. You want to minimize the wrinkles that are under the patient. All right, Mr. Jones, can you come back onto your back and scoot to the middle? You'll feel a big roll. Okay, I'm going to go to the other side of the bed now. Can you scoot toward me, please? And then roll on your side so you're facing that direction. Thank you. We're going to remove the bottom sheet from the bed, rolling it in a ball. And then we'll place this with our other soiled items on the overbed table. We'll stretch out the clean sheet. Attach the corners. Minimizing the wrinkles underneath the patient. Okay, Mr. Jones, can you come back onto your back and scoot to the middle, please? Okay. Now we'll put the top sheet on. We want to open this up and spread it out, being careful not to snap it or shake it. We'll lay this over the patient. Making sure that there's an equal amount of sheet on each side of the bed. And then we're going to tuck the sheet under the mattress. So we'll lift the mattress and pull the sheet so that it's flat under the mattress. We're going to come down about a foot from the end of the bed, pick it straight up. You'll see a triangle here, and tuck in the bottom. We're going to lift the mattress from below, tuck the sheet so that it's flat under the mattress. Come down about a foot from the end of the bed, pick the top flap straight up. You'll see a triangle. Tuck everything else in. We're going to loosen this over the toes. And now I can remove your privacy blanket. I'm going to roll this into a ball and place it with our other dirty items. Mr. Jones, can I take your pillow? I'll bring it right back. We'll remove the pillowcase by holding the pillow and sliding the pillowcase down. We're going to place this with our other soiled items and put the pillow on the table. We'll take the pillowcase, scrunch it all the way up to the corners, and the tag side of the pillow will go into the pillowcase. So we'll stand it up, slide the pillowcase over the pillow, hold the whole pillow and pillowcase, and slide the sides down. The opening of the pillowcase is going to face away from the door. Mr. Jones, can you lift your head up for me? Thank you very much. Are you comfortable?
Yes.
Let me dispose of my supplies, and I'll be right back.
Okay.
These are going to go into dirty linen. And then we'll dispose of our barrier. We'll place our table back and make sure our environment is clean. All right, Mr. Jones, is there anything else I can help you with?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Okay, your call light is right here. If you need anything, just press that red button. We'll be happy to help you.
Thank you.
Bed is in the low position. Environment is clean. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done.
Okay, any questions on that one? No? All right, we're going to take our break. When we get back, we're going to go through another range of motion. Do you guys remember the range of motion that we learned last week? We're going to learn another body part to exercise, but all the same rules apply. So we're just going to apply those rules to a different place. So we're going to take our break. We're going to do range of motion, and then we're going to get into blood pressure. So blood pressure is a skill we have to learn today. All right, good? Okay, let's go ahead and take a break. Does anybody have any questions for me on what we've gone over so far? No? This is an extremely easy skill. So the first two that we saw today were a little bit more complex, more supplies, more steps. This is like super, super easy. So page 78 gives us our overview. We already know how to do range of motion. We've talked about it last class. Somebody with your level of experience should be able to do this within 4 minutes or less, and it will be done on another live testing student. So if you look at page 79, gives you your step-by-step instructions along with the care plan at the top of the page. There's no supplies necessary for this skill. Here's our care plan. It tells us to provide the following range of motion exercise to the resident's right elbow and wrist. Flexion extension. Do you guys remember flexion extension was up, down? So we're going to go up, down on the elbow, and we're going to go up, down on the wrist. It goes on to say provide 3 repetitions of each exercise. So that tells us how many times we're going to do that. And it says the resident is not able to help with the exercise. That means we'll do the work. So this is pretty easy. Knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to exercise your right elbow and wrist. Is that okay? Close curtain, wash hands. You're going to bend the elbow up, like hand to shoulder, and back down like they're making a muscle 3 times, because our care plan says 3 times. And then you're going to go to the wrist and you're going to go up and back 3 times because the care plan says 3 times. And then you're going to do your closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Your environment is clean. Here's your call light. Open the curtain. Go wash your hands. That's the whole skill. It's the easiest skill we do. Hands down. Takes the least amount of time. Questions? Let's take a look at it. So we already know all the principles that we need to employ to do this skill. And we already know range of motion, but we're going to review it. Remember, our care plan tells us which body part, which exercises, and the number of repetitions. We lift from below with a flat palm. We move slowly and smoothly and all the way back to the start position for it to be a full range of motion. Flexion extension is up, down. We are not doing abduction, adduction for this skill, and we're not doing rotation because those were not on our care plan. We're going to monitor for pain and do our closing. Good? So if we apply all of those principles to this checklist, let's see how they're going to get checked off. We're going to do follow our care plan. We're going to do our opening. We're going to evaluate if we need gloves. We'll do the steps of the skill, and we'll do our closing, and that gives us our 100%. Good? So I'm going to have Jake put this video on for us. The video takes, I believe, like 2.5 minutes. It's super, super quick. But while the video is playing, he's going to be passing out blood pressure stuff, because the next skill that we're going to learn is blood pressure. And you'll have some practice time at the end of today for blood pressure. It's kind of built into the program. And I'll talk to you about what blood pressure is, what we need to know, how to take it, all of that after this skill is over. Okay? So Jake will put the video on for us. Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to do some exercises on your right elbow and wrist. Is that okay?
Yes.
Let me close your privacy curtain. I'm going to go wash my hands, get my supplies. I'll be right back. Okay, now that I've washed my hands, I'm going to have you extend your arm out, palm up. I'm going to do all the exercises. All you have to do is let me know if there's any pain or discomfort. I'm going to bend your wrist up towards your shoulder like you're making a muscle, and we'll do this 3 times. So all the way up and all the way back to start. Up and all the way back to start. Feel okay?
Yes.
One more. Up and all the way back to start, making sure the elbow is on the bed. Now we're going to move on to the wrist. We're going to move the hand up and down like you're revving a motorcycle, so light fist. You'll feel a little stretch. Let me know if there's any pain. We're going to go forward and back. Feel okay?
Yes.
Again, forward and back. Still good?
Yes.
One more. Forward and back. Okay?
Yes.
Very good. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Here's the call light. If you need anything at all, press that red button. We'll be happy to come help.
All right.
Your environment is clean. Bed is in low position. We'll go ahead and open the curtain, and I'll go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. All right, any questions? It's one of the easiest skills we do. All right, so Jake passed out your blood pressure kits and a can. We're going to be working together. Please do not go ahead of me. Okay, so don't start playing with your blood pressure cuffs or anything like that. We're going to address this in a very orderly fashion, because if you inflate a blood pressure cuff and it's not wrapped around something, you can actually affect the calibration of your cuff. And we don't want to do that. So we're going to be very careful and stay with me as we do this. On the table are little index cards. I want you to take one of those cards and write your name on it, please. And when you return the kit to us, you're going to put this card in that kit, so we know who had what kit. That way, if the kit isn't, if it's missing something, by accident, we know who to come to. Okay. I've been losing a lot of stethoscopes lately, so, and it's very, easy to just mix it up. So this just lets me know who to go to. Sound good? All right, so if we go to page 56, this is going to be the notes for everything that I'm about to say. The one thing that I want to bring to your attention on page 56 is the title. It says non-tested skills. Non-tested skills. That means that this skill we're going to learn in class, but it's not going to be on the state exam. You are not going to have to perform a blood pressure in any way on the skills part of the exam. Not with an automated cuff, not with a manual cuff. You do not have to perform blood pressure. But you will have a question on the written exam about normals or about techniques. So you need to know how, you need to know normals, because remember, CNAs report abnormals. If we don't know what normal is, we can't report abnormal, right? So we have to learn this skill, but I want you to kind of take the pressure off of you. It's not going to be tested. Good? All right. So we saw this graphic already last class when we were talking about pulse. When your heart squeezes, it pushes out a wave of blood. That wave pushes the one in front of it. That wave pushes the one in front of it. And that wave pushes the one in front of it. And this is how blood moves through your circulatory system. And I gave you the image of a garden hose, turning the faucet on and off, on and off, on and off, on and off, right? You guys remember that? Okay. So when we're thinking about that garden hose for a second, when we turn the faucet on and the hose expands and gets hard and there's lots of water in there, there's more pressure, right? That water is pressure. When we turn the faucet off
and the hose gets squishier, right? And there's less water in there, there's less pressure. Now that's what we're measuring is blood pressure. So how much pressure is inside the artery when a wave is moving through, and how much pressure is inside the artery in between waves. This is our top number and our bottom number of our blood pressure. Good? That's what we're measuring. Okay, so we have names for that. We don't just call them top number and bottom number. We have names. The top number is called your systolic blood pressure. The bottom number is your diastolic blood pressure. So as CNAs, you can just call them top number and bottom number. It's okay, but you do need to know that they have real names as well. So the systolic is how much pressure is inside that artery when a wave is moving through. And the diastolic is how much pressure is inside that artery in between those waves. Normal values. This is going to be on page, what is this page right here? 57, toward the top of the first column. I've got your normal values for you. For our systolic or top number, we really want a value between 100 and 119. That's what is considered normal, between 100 and 119. Diastolic or bottom number, we really want a value between 60 and 79. That's what's considered normal. If we get a value that's not in these ranges, what are we going to do with that information? Report it to the nurse. Absolutely. So all we're doing here is looking for a problem to report. And hopefully it's you're good, you're good, you're good, you're good, you're good. I don't have to report anything. That's what we hope for. But if we get something that's outside of these normal ranges, and it doesn't have to be both of them that's outside, it could just be one. So let's say we've got somebody with a blood pressure of 102 over 58. Well, 102 is normal. That's in our normal range. That's okay. But 58, it's a little bit low. So we would report it because one of our numbers is outside of normal range. Bless you. Make sense? Okay, so it doesn't have to be both that are outside. It can just be one that's outside of normal ranges, and we still report it. All right, so in order to take a blood pressure, if we're going to measure pressure, that means we have to have a number, and this is the gauge we're going to use to get that number. This is called a sphygmomanometer. That's its technical name. I know it's a really big word. Sphygmomanometer. Most people just call it a blood pressure gauge. That's perfectly okay. But all of the blood pressure gauges have numbers on them, and the numbers go up quite high, over 300. So when you're looking at this gauge, it's got a lot of numbers on it. How do we measure the little lines, though? And that's what we're going to learn here in just a second. So when we're taking a blood pressure, the needle's going to start out somewhere around the 0. It can be just a little bit off, but usually right around the 0. And we are going to inflate this cuff, and that's going to make this dial rise. Now, as CNAs, we're looking for normal, right? Who does abnormal? Nurse, that's right. So even though this gauge goes to way over 3-4, I'm not going that far. I'm looking for normal. So as a CNA, when I inflate the cuff and the needle goes up, I am going to stop somewhere around 160 to 180. This is as far as I go. That's it. I don't go over 180. That's not a CNA situation. That's a nurse situation. Got it? Because I'm looking for normal. Okay? Everybody go with me? So as a CNA, we only go up to somewhere between 160 and 180. We got a whole lot more gauge over here we don't care about. So when we take a blood pressure and we inflate it, we squeeze that bulb and we inflate it, that puts a lot of pressure on the arm and it actually squeezes the arm. I'm going to show you inside the body what that does in just a minute. It squeezes the arm. The higher you go, the more it squeezes and the more it hurts. What effect do you think pain might have on blood pressure? It does. It makes it go up. So if we're just looking for normals, right? If we go way up here and we hurt our patient, we're probably going to get a high blood pressure reading. Not because the patient has high blood pressure, but because we're hurting them. And that's a response to the pain we're inflicting. Does that make sense? Good? Good? Okay. All right, so we're going to use 2 pieces of equipment to get this measurement. I'm going to explain how to use the equipment in just a minute, but these are the 2 pieces of equipment we're going to use, a stethoscope and a blood pressure cuff. And right now we're going to talk about the stethoscope first. So if you open your kits and pull out your stethoscope and your blood pressure cuff. Now, if you've got a little extra pieces, parts thing, just put it back in your kit. You don't need that. Okay, so we're going to talk about the stethoscope first. You may have a double tube stethoscope like this. You can have a single tube stethoscope. They both work the same. It's fine. Those single tubes actually have a double tube inside. You just can't see it because it's all under one tube. But this is just more exposed. Okay, same concept. So there's a couple of parts to this stethoscope. They're essentially a big microphone. That's all they are. They amplify the sound. They're a big microphone with some earbuds. That's all they are. But the head of the stethoscope, this is the head of the stethoscope, usually has 2 sides to it. Now, if you have one flat side, this is called a diaphragm. The flat side is a diaphragm. Some of you have 2 flat sides. It's flat on both sides. Some of you have a little cup on one side. This cup is, you can see the difference here. This is a cup. This is a flat diaphragm. Okay. Good, makes sense. The cup is used for something else. We don't use it for blood pressure. It's used for nursing. So we don't use this. Good? Now, if you have a flat side over here, right? If you have 2 diaphragms, which one do you use for blood pressure? Remember, blood pressure, we need the flat diaphragm for. So which one would you use? Well, I am going to listen for. Let me go back here real quick to show you. Oops. I am going to listen for a wave of blood hitting the top of an artery, buried under muscle, fat, and skin. This is not a big sound, guys. This is a wave of blood hitting the top of an artery. Not a big sound. Not a big sound at all. We want the biggest microphone we can get to pick this sound up. Does that make sense? If we use a little microphone, we probably aren't going to be able to hear it. So when we're using our stethoscopes for blood pressure, we want to use the bigger side because we need more amplification. Make sense? Okay. Now, stethoscopes have 2 sides, though. So how do I know which side is on? Because not both sides are on at the same time. If we had both sides on, we would amplify what we're listening to, but we'd also be amplifying everything out here. People jiggling their legs or, moving papers, or even the buzzing of the lights would be amplified, and that's going to override the sound we're trying to hear. So only one side is on. Make sense? Everybody with me? All right. So when you're looking at your stethoscope, there will be some sort of little dot near the head. See if you can find your little dot. Now, if you've got a double tube like mine, It actually, there's a flat side and a curved side. It's the flat side. Everybody find your dot? Everybody find the dot? Okay. We want the large diaphragm to be facing the same way as the dot. This whole head turns. The whole head turns. So you want to position it so that the large diaphragm is facing the same direction as the dot. Good? Everybody got it? Okay. So I bring this up because these are what we call classroom kits. They're loaners. We have them here for you to practice with, but you can't take them home. So if you want to practice this at home, you're going to have to go get your own. You can order them on Amazon. You can get them at Walgreens or whatever. But when you get them, chances are your diaphragm is going to be facing the wrong way. So you have to know how to identify which side you should be listening to and how to turn it. Good? Everybody got it? All right. So that's this end of the stethoscope. This end is much more critical. So when you're looking at your stethoscope and you've got these ear tips, we need that teeny tiny sound. Remember, this is a wave of blood hitting the top of an artery buried under a whole bunch of stuff in our body. Small sound. We need to funnel that sound directly at your eardrum. If it's not going directly to your eardrum, if it has to bounce off your ear canal a couple hundred times, you're going to lose the sound because each bounce degrades the sound. Okay? So we want these to funnel that sound directly at your eardrum for you to pick it up. Good? Okay. So ear tips become very, very important. And for some reason, I don't know why, we tend to put these things in backwards all the time. So your ear tips should face, if you're looking at my ear tips, notice they're not completely straight, okay? So they're not like this. The ear tips should not be completely straight. They should actually face a little bit in one direction. And you can turn these. These actually, you can turn them all the way around. You can turn them. So we want these faced just a little bit in one direction. And when you put these in your ears, you want to make sure, and you can adjust them for your ears, but you want to make sure that they are facing away from you. They do not go in like this. They need to face away from you. You guys see that? Away. So when you're putting your ear tips in, see how this one faces forward? That's how we want them to go into our ears. So take your ear tips, put them in your ears so they're facing away from you, and very gently tap your large diaphragm. It should be amplified. Okay. Now, take your ear tips out. Just flip the whole thing over so they're facing you. Put them in and try it again. Not nearly as loud, is it? Take it out, put it in the right way again. Do you guys see why we have to put these in the right way? When you are practicing at home, this is the #1 mistake that people make when they're trying to learn blood pressure. They put their stethoscope in the wrong way and then they can't hear anything and they get frustrated. Since I'm not home with you, I need to train you to look at that. Good? Make sense? Okay. All right, so that's how to use your stethoscope. This is a very common error. So now let's go to the blood pressure cuff. Go ahead and open your blood pressure cuff. It's got Velcro. All right. This is a professional cuff. Professional cuffs have a measuring guide built right in. So on one of the narrow edges, we have a white stripe. You guys see your white stripes? This allows me to figure out whether this cuff is going to fit my patient. They're one size fits most, but not one size fits all. Can I borrow you for a second? Can you come over? You can just set your blood pressure cuff aside. She has small arms. I'm concerned that this cuff might be a little too big for my patient. So what I would do is have her stretch her arm completely flat. I'm going to take this white stripe and put it underneath her arm about above the fold of her elbow. Okay. So I'm going to wrap it around her arm right there. Now, this, if it wraps more than halfway around her arm, it's too big for her. This is right about half, so she's good. So if it wrapped more than halfway, it would be too big for my patient. If I put this under her arm and I can't see either corner, okay, if her arm covers that whole line, it's too small for her. I would need a bigger cuff for my patient. Thank you. Okay, so this is what this white stripe is for. It's to be able to measure whether this cuff is going to fit our patient. Now, what's the problem with using a cuff that doesn't fit? If you use a cuff that's too small for the patient, then the blood pressure is actually going to look higher than it really is. If you use a cuff that's too big for the patient, the blood pressure we get will be lower than what the blood pressure actually is. Good? Because it's got to be able to exert the right amount of pressure at the right space for the pressure to be accurate. Make sense? All right. So I have to give this warning because people tend to get ahead of me as we go through this. Please don't inflate your cuff until we get to that point. Okay? I don't want you to knock my cuffs out of calibration. All right. So we have hanging off of our cuffs 2 tubes. One of those tubes leads to a gauge. The other one leads to a bulb and valve assembly. We just call it the bulb. On the cuff itself, you have a little fabric loop thing. And below that, you've got a label that probably says right arm, left arm. So these are the components of our cuff. Good. This gauge, sphygmomanometer, on the back of it has a little clip. If you press down on the bottom of the clip, you got to press down on the bottom, the top magically opens. This loop, if we open our clip and slide it up the loop, it will securely attach to our cuff. You want to keep your gauge attached to your cuff. There's no need to take it off. So you want to put it on your cuff and leave it there. I know it has prongs. We do not use the prongs. We use the clip. If we just set this here with the prongs, when I go to put this on the patient, that's what happens. And your patient's wrist is right there where this is going to hit. Feel how heavy that gauge is. That can do some real damage when it hits a wrist. We don't want this gauge unattached from our cuff where it can injure the patient. Good? Questions so far? All right. So now let's learn how to read that dial. If you're looking at the dial, you'll notice it's marked in 20s. So I have a line for 20, 40, 60, 80, 100, and so on, all the way around. Good? There's lines in between your 20s. So there's a whole bunch of lines here between 40 and 60. The larger line right in the middle are your 10s. So if I'm looking at this, this is 40, there's 60, there's 80. So the line in between 40 and 60 is going to be 50. There's 60, 70, 80, 90, 100, 110. Those aren't marked. They don't have the actual numbers on them, but that's what those lines mean. Now, those little itty bitty teeny tiny lines in between are twos. So if I have this line here at 40, this is 42, 44, 46, 48, and 50. Good? Twos. There is nowhere on this gauge, there is no line on that gauge for 57, for 93, for 117. There are no lines for odd numbers. The lines are all even numbers. So when you are giving a blood pressure to somebody, right? If you come to me and you're reporting a blood pressure that you got and you give me odd numbers, I know you were guessing. Because there are no odd numbers on this gauge. If you tell me that the blood pressure is 113 over 79, I know you were guessing. And I'm not going to trust your reading. Make sense? Good? Okay. So when you're giving blood pressures, it's always best to stay on even numbers. Because that's what the gauge gives us, is even numbers. Now, automated machines can give us odd numbers because they're much, much more accurate than we are. Good? Good. You'll see why in just a minute. All right. So we have the gauge, which is how we get our numbers. And now we've got to figure out how to use the cuff to get those numbers. And that's where the bulb and valve assembly comes in. This guy kind of looks like a little hand grenade. When you're holding this, you want to hold it in your dominant hand. So if you're right-handed, you hold it in your right hand. And you hold it so that the tube points up, not like this. It does not get held like this, where the tube goes down. You have to hold it so the tube points up. And you want to hold it so that little gauge, the little valve, the little circle thing, is facing you, not like this. We don't hold it like this. You hold it in the palm of your dominant hand with that gauge or that valve facing you. Now, that valve is how we're going to put air in and let air out, and we are in control of how fast all that happens. Totally up to us. So in a few minutes, if your gauge goes woo all the way down super quick, that's you. It's not your gauge. It's not your blood pressure. That's you. You let the air out too fast. Next time, go a little slower. If your needle completely stops, that's you. You got to open it up a little bit more. Okay? You are in total control through this apparatus of how quickly that needle moves. Tiny motions is what we're going to go for. And when I mean tiny, it's like Thumbelina size motion, tiny. You should not even be able to see this dial move. It's that small. Okay, you're going to see that in just a minute. Tiny motions. Good. Questions so far? Have I lost you? Okay. So this dial held in your hand facing you, right? That little dial, righty-tighty, lefty-loosey. Good? You guys ever hear that before? Righty-tighty, lefty-loosey?
I still say that.
Yeah. Righty-tighty, lefty-loosey. So we are going to turn that. We're going to hold that bulb and valve assembly in our hand with the little dial facing us. And we're going to turn it to the right, but just until it stops. Don't tighten it. Because we're about to loosen it. And if we tighten it down and then we try to loosen it, we have to go, ugh, to loosen it. And then our needle goes, woo, all the way down. And we missed our numbers. So we just want to go until it's closed, not tight. Got it? So what I do, because I'm real bad about over tightening it. Like I'm the type of person that will crank that thing down to tighten it. So to keep myself from doing that, what I do is tighten it with just my thumb. I turn it to the right with just I can't tighten it down with just my thumb. Make sense? I just turn it. See what my thumb is doing here? That keeps me from over tightening it. Now, when I go to loosen it, I don't have to give it a lot of oomph to loosen it. Okay, good. Good. All right. So when we close that valve, we're going to pump the bulb until that needle gets up to somewhere between 160 and 180. Remember, that's our stopping point. So we're going to pump that bulb until that needle gets up to 160 to 180. And then we're going to ever so slightly open that valve just a tiny bit until that needle starts to come down. And as that needle is starting to travel down, we are in control of that motion. So if the needle starts to slow down, you got to open it a little more. Good? Everybody got it? All right. So we're going to inflate to between 160 and 180. And when we do that, this is our cuff. We've got it on the upper arm above the elbow. I'm going to show you where and how to do all that in just a minute. But I want to explain to you what's happening inside the body when we're taking a blood pressure. So we have this cuff on the upper arm. We've closed our dial. We've inflated it until our needle gets up to about 180. And when we do that, that cuff, the air inside that cuff presses inward on those muscles. And when we press inward on those muscles, they close off that artery. We shut it down. So we still have a heart that's beating. We're better, because otherwise your patient's dead. We still have a heart that's beating. So thump, 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 thump. But those beats can't really get through the obstruction that we put in place. So we don't want this to take a long time. Good? Okay, so we've got this artery closed. Now what we want to do is open the artery little by little. We just want to, just in increments, open that artery a little bit, a little bit, a little bit, a little bit. So think of our hose, okay? We want to open the valve just enough for water to come through. We're looking for a trickle, basically, okay? So when we open it little by little, using that dial, little by little, that needle is going to come down. And as that needle comes down and our artery opens a little bit, a wave is going to be able to make its way through. Now, we are listening on the other side of that cuff. We're listening here. When that wave is able to push its way through, that first wave, so it's going to be quiet, 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 because no waves are coming through. Quiet, 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 no waves coming through. Quiet, 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 no waves are coming through. And then all of a sudden, the artery is opening up, that the first wave comes through and we hear it. It makes a thunk sound. Where that needle is on our dial, when we hear that thunk sound, where the needle is pointing to, that is our top number of our blood pressure. Now that thunk sound actually has a name. It's called a Korotkoff sound. You don't have to know that, but it's just good to know. Korotkoff sound. So where the needle is, when we hear the first thunk sound that tells us the first wave went through, the number that needle is pointing to, that is our top number of our blood pressure. So if we're looking at this dial, there is our line for 100. There is our line for 110. This is one line below 110. What is that? 108. So what is the top number of our blood pressure? 108. Okay. There's no addition, multiplication, division. No math here. It's just where is the needle? Good. So 108 is our top number. So that's how we get the top number of the blood pressure. We inflate to 160, 180. We deflate very slowly. And we listen, and it's going to be quiet, 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 nothing happening, nothing happening, nothing happening, thunk. Where is the needle when you hear that thunk? That's your top number. Well, if one wave could make it through, well, then others are going to be able to make it through, right? So you're going to hear more thunks. The first one is our top number, but then we're going to hear more thunk, 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 thunk. As we hear those other thunks, we don't care about those. They don't count for blood pressure. They make no difference in our life at all. What we're listening for here is the last clear thunk, because the last clear thunk means the artery is so open that those waves aren't hitting the top of it anymore. Okay? So that tells us how much pressure is inside that artery at rest. So we're going to inflate our cuff. We're going to deflate the cuff, and it's going to be quiet. Quiet, 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 thunk. That first thunk we hear where the needle is, that's our top number. We're going to hear more thunk, 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 thunk. And those get a little bit quieter as they go. Because remember, our artery is getting bigger and bigger and bigger. So it's harder for the ceiling, right? So it's not as much of an impact. So it's a little quieter. So thunk, 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 thunk. Oh, where was that last one? The last clear one I heard. Wherever the needle was, that's my bottom number. But do you see how that can be really hard to pick up? Because you don't know it's the last one until it's gone, until it's passed. So we inflate, we deflate, quiet, 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 thunk, top number, thunk, 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 bottom number. So you have to pay attention to each one of those. Each one of those waves you have to pay attention to, because any one of them could be the last thunk. You won't know if it's the last thunk until after it has gone. Good. So in this scenario, okay, so the last thunk means no more are going to be heard after it. So remember, when we do this, you're going to inflate and you're not going to hear anything. And then you're going to hear a thunk, 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 thunk. And then the last one, and they're not going to hear anything again. So silence at the beginning, silence at the end. It's the ones in the middle is where the sound is going to happen. Good. Okay. All right. So wherever that needle is pointing, when we hear our last clear thump, wherever that needle is pointing on our gauge is our bottom number. Where's the needle pointing? 62. So this person's blood pressure is 108 over 62. Correct. So it's not nearly as, difficult as people make it seem. Not technical. But there is a lot going on here. In theory, it's pretty easy. You inflate the cuff, you deflate the cuff, you listen for the first, you listen for the last. In theory, it's easy. The problem is that not all blood pressures are easy to hear, right? Some of them are super low, like they're really hard to pick up. Some are great. I mean, you can hear them from like across the room, thunk, 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 right? They're easy. Everybody has a little bit different sound quality. But you also have outside noise because we don't work in a quiet environment. So you got a lot of outside noise that you have to be able to overcome. And this, unfortunately, takes a lot of practice. You're not going to be accurate today. It takes about 45 blood pressures before you even start to get accurate. That's a lot of blood pressures, guys, before you really start to dial this in and get the hang of it. The first couple blood pressures you take, you're going to feel like you need another hand. There just isn't enough hands to do what you need to do. A little bit of practice, you'll kind of dial in your technique and it'll be okay. But the first couple, you're going to be all over the place, and that's okay. That's where you're supposed to be when you're learning. Okay, good. Good. Any questions so far? All right. So our normal values are 100 to 119 for our systolic or top number. Our bottom number, 60 to 79, that's our diastolic. These are normal values. Anything outside of this gets reported to the nurse. Question? Jake, can you get that? Okay. So we want to... Hi. Oh, you're fine. You're fine. Okay. So we want to make sure that we're deflating, even though we heard the last thunk somewhere up here, right? We don't stop. We keep deflating until we get to 0. Your blood pressure doesn't end until your needle's on 0. Don't forget that step. We get so excited when we start to hear it, right? We get so excited. Like, oh, I heard the thumps and the blood and the needle's still hanging out somewhere over here. Remember, that's still putting pressure on your patient's arm. So get that needle to 0 before you celebrate. And then you can remove your cuff. All right, so to recap, the number where we hear the first thunk is our top number. The number where we hear the last clear thunk is our bottom number, and that makes up our blood pressure. But where we listen matters. Where we listen matters. And your artery is not where you think it is. Remember that we are listening for an artery, right? An artery, not a vein. So if you look at your elbow area, right, you've got a vein that's very prominent right in the middle. We can, you know, that vein is pretty easy. That's not your artery. That's a vein. Completely different creature. We have to find the artery. And the way that you find an artery is to use 2 fingers, fingertips, not flat part, not your thumb. Have we heard this before? Right? It's a pulse. An artery is a pulse. So we're going to use our fingertips, not the flat part, not our thumb. And you're going to stretch the arm out completely flat. Don't let it sag at all. We want that elbow popped all the way out. At the fold of the elbow, on the inside, like on the pinky side, on the not the thumb. Remember, radial was over here at the thumb. This one is brachial. It's pinky. Come on through. It's okay. It's okay. So, oh, you're fine. You're going to take 2 fingers at the fold of the elbow on the pinky side. We're going to put our fingers there and put our thumb on the back. Remember how important that thumb was? We're going to put our thumb on the back. Remember, it's not in the middle. If you're in the middle, you're not going to feel your thumbs. It's got to be on the inside. Inside by your pinky. See if you can find your thumps. I'm going to come around and help you. Did you find it? Find it? Got it? You've got a lot of muscle there, a lot of tissue. It's right here. Do you feel how hard I'm pressing? Okay. Got it? Good. Okay, you're a little too close to the middle. We want it to be more here, right there. Got it? Got it? Got it? Bring your fingers just a little bit more on the inside toward your body, a little bit more. No, we're going to go right there. Push harder. Got it? Okay. All right, everybody find somebody else's. Grab a partner. Find an artery. More on the pinky, more closer to the pinky. Keep coming my way. There you go. You're not getting it? Okay. Okay. I don't know if you're pressing hard enough. Okay, let's try this one. You couldn't get it on this side? Press a little harder. Okay, let me see. Watch what my fingers do. Okay, I push this way, and kind of settle in there. It's right here under my fingers. Do you see how hard I'm pressing? Okay, it's right there.
I was thinking about that too.
Yep. So what happens in some people, let me get on camera here so I can show you. So what happens in some people, I want to give you a little visual here. In some people, we have an artery, okay? And that artery is in the arm. But there are some people who have a muscle and a tendon on top of that artery. So if I lay my fingers right on top, I'm probably not going to feel that artery. There's too much stuff in the way. What I want to be is on the artery, not on a muscle, right? So what I do is I put my hand there and it doesn't take a big motion, but just a little wiggle, left, right, and center. And when I do that, what I'm doing is I'm pushing the muscle and the tendon out of the way so I get on top of the artery. So just a little wiggle, left, right, and then kind of center it in. And it often will help you pick up those arteries that are harder to feel. Make sense? Now, super, super important that the patient's arm is flat, like that elbow is completely popped up. So if you find your artery, right, pop your elbow up, and if you find your artery and you have your fingers on it, let your elbow relax a little bit and see what happens to your artery. Can you feel the pulse as well when your arm is bent? You can't because the artery sags down and it's harder to pick up. So when you're trying to find somebody's artery so you can get the cuff in the right spot and you can get your stethoscope in the right place, because where we listen is going to impact what we hear, right? Make sure that elbow is completely popped out. Most people will do this. Just that little bit of relaxation will affect how you hear the thumps, because remember, your artery is way down deep now. You're not going to hear it as well. Good? Does that make sense? So we want that arm just as straight as we can get it to be able to hear effectively. Questions so far? No? All right. So years and years and years ago, when we first started doing blood pressures, we would find the artery. And now I've got to be able to remember where that artery is when I go to take the blood pressure, right? So I find the artery, I put the cuff on, and then where's the artery? And then I got to put the stethoscope there. So we used to take a little pin and we used to just put like a little dot where we felt the artery. So now we know where to put our stethoscope. Make sense? Patients don't like you drawing on them. So what we do now is use our cuff. On the cuff, below the gauge is a label that's sewn on there. And that label has a right arm and left arm with arrows. You guys see that? Now, if you buy a cuff like off of Amazon, or if you go to Walgreens or whatever and get one, you may not have that little patch. You might just have a line with a circle on it. And again, it's the same thing. That's an artery marking. So what we do is we figure out which arm we're going to be using. We have it supported on a table or something so the patient isn't holding it up. And then we place this over the upper arm. We want it above the fold of the elbow. We don't want it down here. We want it up above the lines. You're going to find the artery, set it in place, find the artery, and then line up the arrow with where you feel the artery. And now this becomes your mark. Now you know exactly where to put the stethoscope. Of course, you're going to secure the cuff. I can't do that right now. You would secure the cuff. And now you know exactly where to put the stethoscope because the arrow is telling us. Good. That's what this is for. You can't just lay this on the arm and hope that the arrow lines up, and you have to find the artery and line the arrow up with it. Does that make sense? Good? Good. Okay. So where you listen is going to matter. It's going to affect what you hear. All right. Now, we're going to practice this together. You're going to need to zoom. So you're going to take your can and your cuff, and you're going to wrap your cuff around your can as snug as you can, securing it with a Velcro. You're good. You will need to get it tighter in just a minute. This extra flap, just wrap it around the back. Now you're going to hold this whole can thing in your non-dominant hand, because remember, your bulb and valve assembly are in your dominant hand, right? So I'm going to hold this in my non-dominant hand. There you go. Good job. Now I'm holding the bulb and valve assembly in my dominant hand. Can everybody see the screen? Everybody good? Okay. So remember I said we have to close this righty-tighty. So I use my thumb just until it stops. I don't over-tighten it. I just turn it till it stops. And then I'm going to squeeze this bulb until this needle gets somewhere between 160 and 180. Now, please bear in mind that I'm in a very awkward position here. We're going to go up to somewhere between 160 and 180. And I'm going to hold this little valve and turn it ever so slightly to the left so my needle comes down. And this is about the speed that you want it to go. Now it will slow down and stop on you, so you have to keep opening it and keep opening it and keep opening it and keep opening it until it gets to 0. I want you guys to try it to learn how to control the descent of that needle. So close your valve, pump up to 160 to 180, open the valve ever so slightly so the needle comes down, and you want to go all the way to 0. And I want you to do that a couple of times to get the mechanics of it. If the needle slows down, you've got to open a little more. If the needle goes too fast, you opened it too much. But inflate and deflate a couple of times so that you kind of get the mechanics down a little bit. And then when you're comfortable that you know how this works, you can take your cuff off of your can.
You know, Miss Patty, I'm pretty old, and I had one of those old school doctor kits with the plastic Band-Aids and everything. My blood pressure cuff was never this cool.
That's true. I grew up with those. Yes. Yes, I was the kid who used to bandage my dog. I always knew I'd be in healthcare somewhere, somehow.
I used to do it for my grandma.
Okay, so to recap here, we're going to inflate our cuff to somewhere between 160 and 180. We're going to deflate it slowly, and we're going to listen for the first clear or the first thunk. You'll hear more. We don't care about the ones in the middle. We're listening for the last clear thunk. The problem is any of those in the middle could be our last one, right? We won't know it's the last one until there's no more after it. So we inflate, we listen for the first, we listen for the last. And then we deflate all the way to 0. Any questions? All right. So I want to talk to you about a couple of things real quick. When we are taking a blood pressure, it is best for your patient to have both feet flat on the floor. Not crossed at the knees, not crossed at the ankles. Okay, you want both feet flat on the floor. Cross at the ankles actually doesn't have any measurable impact on blood pressure. Crossing at the knees does. We don't want you to have to remember, so we tell everybody feet flat on the floor. Okay, good. The other thing that we have to think about is which arm can we use? If the patient has 2 arms that can be used and they don't have a preference and they don't have a medical reason not to use one, try to use the left. There is a little blood pressure difference between the right and the left arm. Okay, there is a measurable difference. So if everybody is taking a patient's blood pressure and we're going to compare those readings, then it would be best if everybody was on the same arm. Make sense? So if you have a choice, left is best. If the patient has a reason that we cannot use a specific arm, so if they've had a mastectomy or breast removal, usually we take the lymph nodes too, and that keeps us from using that arm for blood pressure. We can't use it anymore. If they have dialysis and they have a shunt or a graft that was surgically created in the arm, we don't want to use that arm. If they played Humpty Dumpty and we had to put them all back together again and they got plates and screws and rods and stuff like that in one arm, we don't want to use that arm. If they've had a stroke and one side is affected, we don't want to use that arm. So basically, we want the healthiest arm the patient has. If the patient has any of those conditions, they have been told, do not let anybody take a blood pressure in that arm.
I have a cousin who actually had a double mastectomy. What would she do for blood pressure and how would they get an accurate reading?
Okay.
If you can't use the arm?
So I'm going to go back to something we talked about on day 1. CNAs do you remember what the next word is? CNAs do normal. So is taking a blood pressure on somebody with a double mastectomy normal? No. So who would have to do that blood pressure? The nurse. Okay, so that's number 1. That's not going to be a CNA task. But to answer your question, what happens in a mastectomy, okay, is we take the lymph nodes. Now, the lymph nodes are your body's water recycling plant. So when we take a blood pressure and we inflate that cuff on the arm, that keeps blood from going in, but it also keeps the blood that's down there from coming out. As that blood in the bottom part of the arm stays in place for too long, there's a principle, okay, that it's very scientific, but anyway, what's going to happen is all of the fluid part of the blood is going to leave the vessels into the tissues to make room for the blood that's in there, okay, because it can't move. It's stuck. There's a toll booth there that it can't get past. So we end up with fluid in the tissues when we take a blood pressure on somebody. Anybody, everybody, we end up with fluid that escapes the vessels into the tissues. Now, in you and I, it's not a big deal because we have the lymph system, the water recycling system. The lymph system collects all that excess water, cleans it, and puts it back into circulation, and you and I are none the wiser. No big deal. But in somebody that doesn't have that system anymore, we have fluid in the tissues and we have no way of getting it out of the tissues. So we end up with swelling. And we end up with swelling that doesn't go away because there's no method there to reclaim it. Does that make sense? So as a nurse, I'm going to take blood pressures only when absolutely necessary. Now, the accuracy isn't affected. They'll still be accurate, but I do know that there's going to be swelling involved. So when I take the blood pressure, I'm probably going to elevate the arm so that I don't have gravity working against me. It's working with me. I'm also going to take the blood pressure very rapidly. So I'm limiting the amount of time that we have that compression. And I'm not going to inflate any further than I absolutely have to. So I'm looking at their normal values, what we know is their normal. We're not going to go much above that, and we're going to see where we're at. Does that make sense? So
I'm just genuinely curious. I'm like, if you can't, like, I mean, as a CNA, I know
Yeah.
but anyway, but
right.
what does that do for everybody else in healthcare with somebody in that position?
The other thing that I'm going to think about in certain situations are things called compression garments that provide outside compression that forces that fluid back into the torso for where we do have lymph nodes for circulation. Okay, so I've got some tools that I can use, but again, we're only going to take blood pressure when we absolutely have to. We're not doing screenings on these people. Okay. Great question. Great question. So if we have a patient that has a certain situation, where would we go to find that information? If they have an arm that we can't use, how would we know that? The care plan, that's right. So we're going to have care plans that say blood pressure left arm only. We can also ask the patient, which arm can I use? I always ask the patient, which arm can I use? I don't rely on the care plan because somebody may have dropped the ball somewhere. It's possible. Good. I don't want to cause that patient any harm. Any questions so far? No? So again, you're going to place the cuff on the arm. You're going to find the artery, line up your arrow, secure the cuff, and you want it snug against the arm. You want that cuff snug so it doesn't slide down. We're going to put our stethoscope here, put the ear tips in facing away from us. We're going to inflate the cuff so that the needle goes up to somewhere between 160 and 180. We're going to deflate the cuff slowly and smoothly, and we're going to listen for our thumps. Where is the first thump? Where is the last thump? Get all the way to 0, take the cuff off. That's the blood pressure. It's not nearly as hard or as scary as it sounds originally. Good? Questions? All right, in your book, I don't think I've got, oh yeah, I do. In your book on page 57, on the right-hand side of page 57 is our gray box of questions. If you go down to number 8, there's a little graphic there, and it shows you where we heard the first thump and where we heard the last thump. Can somebody tell me what the blood pressure is for this patient? 130/90. Everybody get that? 130/90. Do you see why it's 130/90? The first thump was heard at the space or at the line between 120 and 140. That's 130. Good. Is that a normal blood pressure, 130/90? What would you do if you got that blood pressure? Report it to the nurse. Very good. Now let's look at number 10. There's a graphic there as well. I know it's kind of hard to pick out. I know, guys, but can somebody tell me about what that blood pressure is? 108 over 62. Is that a normal blood pressure? Yes. Man, I wish I haven't seen a blood pressure like that in like 40 years. I wish I had that blood pressure. As a CNA, you are expected to know how to take blood pressures, but you're more expected to know how to recognize abnormals. Okay? Because even if we're using automated blood pressure cuffs, which we normally do in most settings now, you're not going to be taking a manual blood pressure very often. It's almost always automatic. But you need to be able to recognize abnormals so that we can get that report to the nurse quickly so the patient can get the right treatment that they need. This is not a skill that you should fake it till you make it. You're putting your patients' lives at risk if you do. This happened to me recently. I have a situation where my blood pressure spikes very high, very quickly. And I knew I had taken my blood pressure at home. I knew what it was. I went to the doctor and the medical assistant took my blood pressure, but she did it very, very quickly. She only inflated up to 120 and the needle went woo all the way down. And she says, oh, you're fine. You're 120 over 70, textbook perfect. I said, no, I'm not. And I know I'm not. And I need you to retake it. And she gave me an attitude. And I said, please retake the blood pressure, but you need to go up quite a bit higher. So she took the blood pressure and once she was done with the blood pressure, she looked at me, her eyes were super big. And she said, are you okay? I said, I'm fine, but that's why I'm here. My blood pressure at that time was something like 240 over 160. She hadn't even gotten to the blood pressure and she faked it. Now, thankfully, I knew what my blood pressure was. I know the problem that I have. I know how we're treating it. I was in control of that situation. But what if I wasn't? What if I was a regular run-of-the-mill patient and she did that? And that patient walked out of that building with a blood pressure that was probably prone to inducing a stroke. You are entrusted with taking blood pressures, but understand that this is the one skill that is truly life or death if you get it wrong. Because if you don't get a high blood pressure when the patient has one and they don't get treatment, it can absolutely ultimately kill them because you failed to recognize a problem that needed immediate intervention. Does that make sense? It's not a hard skill to master. But if you can't get the blood pressure, it's your responsibility to tell the nurse, hey, I can't get this blood pressure. You need to check it. Don't fake it. Good. Now, Jake has an even scarier story than that. He used to run our retail store. We had the uniform store here in town. And he had a couple that was in shopping, and the man was shopping for scrubs. And the woman he was with said, don't you need a new stethoscope? And he says, no, I'm not really worried about it because if they're fat, I say that they have high blood pressure. If they're skinny, I say they have low. How many things are being missed because we don't have the right ethics? Way too many. So my job is to make sure that you understand the importance of what you're doing. Good. If you can't get the blood pressure, there's no shame in that. Go find a nurse. I can't get it. It's too high. I can't hear it. Perfectly okay. I'd rather you come to me and say, hey, I'm not getting it, than give me a number that's total and complete baloney. Good. Because of this, There are a lot of states that do not let CNAs take blood pressures, not with an automated cuff, not with a manual. You are not allowed to do blood pressures at all because of the importance of this, because too many things are getting missed. Florida's not one of those states, but it could be if we aren't ethical. Good? Make sense? Okay. So we are going to practice blood pressure on each other in just a few minutes. So you're going to break up into groups of 2. You're going to take each person's blood pressure, and then you're going to switch groups in just a few minutes. Before we do that, though, I'm going to sign off of online because they don't need to be part of this. Okay. So I'm going to sign off of online, but I'm also going to pass out the review sheets for today. You are going to get a 2 review sheets for today. Let me go here. This is a new one that I just created that you're going to get for today, and it's for chapter 4 in your homework. So tonight you're going to go home and read chapter 4 in the homework, and chapter 4 is all on body systems. Chapter 4 is unnecessarily complicated. I don't think it should be that complicated. I don't like the way your yellow book gives us the information. So I created this study sheet for you. This is what you need to know about chapter 4. So when you're reading through it, just refer back to this sheet so you can kind of understand. This is going to kind of help you break down what you need to know. All right. So I just created this for you guys. And then you're going to get your review sheet for today as well. Please remember that you do get the wrap-up emails that are going to have links to everything that we talked about. And if you have not registered for a CPR or first aid class, or you don't have your CPR and first aid, you don't need it for the class. Review sheets, Jake, please. You don't need it for the test, but you will need it to work. So it's something that you probably need to be thinking about, is getting your CPR. And this QR code will lead you directly to Julie's site where she gives you a discount. So you don't get a discount unless you go through the QR code. It's also on your first day flyer that I gave you, the blue flyer. It's on there as well. Okay. Good. All right, Jake, you can go ahead and pass out the 2 review sheets. In the meantime, I'm going to go ahead and sign offline. Thank you guys so much for joining us today. Tomorrow is the game show, so please make sure that you tune into our YouTube channel. It's the only place that we broadcast the game shows directly on our YouTube channel. So go to foryourcna.com or youtube.com/foryourcna. I'll be live at 11. We'll go over 15 test-like questions and discuss the answers so that you know not just what you're going to be tested on, but how you're going to be tested and how to answer those tricky questions that come up to make sure that you pass the written exam the first time. So tomorrow morning at 11 a.m. directly on our YouTube channel for the game show, and we'll see you there. And you could win some really cool new prizes as well for coming in first, second, or third. So until next time, happy caregiving. Bye.